International Wardens, embracing global outlook. We are
Good morning, everyone. May I have your attention, please? We kindly invite all participants who have joined the Zoom meeting to complete the pretest available on the LMS. You will have 15 minutes to complete the pretest. Please ensure that your responses are submitted before the allotted time ends. Thank you for your cooperation. Dear all participants, the allotted time has ended. Please ensure that your responses have been submitted through the LMS. Thank you. We will now proceed to the next session.
Attention please. International Webinar on Midwifery Student Association 2026 at Tasikmalaya Health Polytechnic Ministry of Health is going to be started. Dear participants, welcome to the International Webinar on Midwifery Student Association 2026. Golden Indonesia begins. Smart parenting, managing stunting in children to prevent double the risk of diabetes mellitus in realizing a healthy and intelligent generation at Tasikmalaya Health Polytechnic Ministry of Health.
Assalamualaikum warahmatullahi wabarakatuh. Good morning to our distinguished speakers, honorable guests, respected lecturers, and dear participants. First of all, let us praise to Allah Subhanahu wa Ta'ala. Alhamdulillah, by His blessing and mercy, we are able to gather here today in good health to attend the International Seminar on Midwifery Student Association 2026. May peace and blessing be upon our beloved Prophet Muhammad SAW, his family, his companions, and all of us, his followers.
Recording in progress.
The Honorable Director of Tasikmalaya Health Polytechnic Ministry of Health, Mrs. Dr. Dini Mariani, Bachelor of Nursing, Registered Nurse, Master of Nursing.
Our distinguished speakers, Mr. Rizal Myohain, Bachelor of Medicine and Bachelor of Surgery, Doctor of Philosophy, Assistant Professor at the College of Medicine, Ajman University, United Arab Emirates, and Visiting Associate Professor at University Malaya, Malaysia.
Mrs. Dr. Amy Shay Alfiar Barion, Registered Nutritionist Dietitian, Doctor of Philosophy, and Associate Professor at the Institute of Human Nutrition and Food, University of the Philippines, Los Baños, Philippines.
Mrs. Dr. Norbaizura bin Muhammad Yusuf, Doctor of Philosophy, Senior Lecturer and Clinical Dietitian at the Department of Dietetics, Faculty of Medicine and Health Science, University Putra Malaysia, Malaysia.
Mrs. Wiwin Mintarsih Purnamasari, Bachelor of Applied Science in Midwifery, Master of Health Sciences, Lecturer of Midwifery at Tasikmalaya Health Polytechnic, Ministry of Health.
Mrs. Pepi Hapitria, Bachelor of Applied Science in Midwifery, Master of Public Health, Lecturer of Midwifery at Tasikmalaya Health Polytechnic, Ministry of Health Cirebon Campus.
The Honorable Head of Midwifery Department at Tasikmalaya Health Polytechnic, Ministry of Health, Mrs. Dr. Yati Budiarti, Bachelor of Applied Science in Midwifery, Master of Midwifery.
The Honorable Secretary of Midwifery Department at Tasikmalaya Health Polytechnic, Ministry of Health, Mrs. Sri Gustini, Bachelor of Applied Science in Midwifery, Master of Midwifery.
The Honorable Head of the Associate Degree Midwifery Study Program at Tasikmalaya Health Polytechnic, Ministry of Health, Mrs. Yulia Herliani, Bachelor of Applied Science in Midwifery, Master of Midwifery.
The Honorable Head of the Associate Degree Midwifery Study Program at Tasikmalaya Health Polytechnic, Ministry of Health, Cirebon Campus, Mrs. Lia Nur Cahyani, Bachelor of Applied Science in Midwifery, Master of Public Health.
The Honorable Head of Applied Bachelor's Degree Midwifery Study Program at Tasikmalaya Health Polytechnic, Ministry of Health, Mrs. Dede Gantini, Bachelor of Applied Science in Midwifery, Master of Midwifery.
The Honorable Head of the Applied Bachelor's Degree Midwifery Study Program at Tasikmalaya Health Polytechnic, Ministry of Health, Cirebon Campus, Mrs. Dr. Yani Fitrianingsih, Bachelor of Applied Science in Midwifery, Master of Health.
The Honorable Head of the Midwifery Professional Program at Tasikmalaya Health Polytechnic, Ministry of Health, Mrs. Ir Khoiriyah, Bachelor of Applied Science in Midwifery, Master of Midwifery.
The Honorable Coordinator of Student Affairs for the Midwifery Department at Tasikmalaya Health Polytechnic, Ministry of Health, Mrs. Bayu Irianti, Bachelor of Applied Science in Midwifery, Master of Midwifery.
The Honorable Heads of Study Programs at all universities throughout Indonesia who are willing to attend this morning or their representative.
The Honorable Head of Tasikmalaya Ministry of Health or the representative.
The Honorable Chairman of the Student Legislature or their representative. The Honorable Chairman of the Executive Board or his representative.
We warmly welcome all participants to the International Webinar on Midwifery Student Association. Golden Indonesia begins with smart parenting, managing stunting in children to prevent double the risk of diabetes mellitus in raising a healthy and intelligent generation. On Friday, July 17, 2026. Dear all participants, let's open this event by properly saying Basmalah together. Bismillahirrahmanirrahim.
Recitation of the Holy Quran, followed by the recitation of its translation, to be delivered by Shifa Fadilatu and Raisa Hana. The stage is yours.
Assalamualaikum warahmatullahi wabarakatuh. A'udzu billahi minasy syaithanir rajim. Bismillahirrahmanirrahim. إذا قيل لكم تفسحوا في المجالس فافسحوا يفسح الله لكم وإذا قيل انشزوا فانشزوا يرفع الله الذين آمنوا منكم والذين أوتوا العلم درجات والله بما تعملون خبير صدق الله العظيم.
most gracious, the most merciful. You have believed when you are told, space yourself in assemblies. Then, next page, Allah will make space for you. And when you are told, arise, then arise. Allah will rise those who have believed among you, and those who were given knowledge by degrees, and Allah is acquainted with what you do. Allah Almighty has spoken the truth. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Shifa Fadilatu and Raisa Hana. May the recitation of the Holy Quran and its translation be a source of blessings and guidance for us all.
Singing the national anthem of Indonesia Raya and Mars Poltekkes Kemenkes. To our distinguished speakers, honorable guests, and dear participants, please sit up straight.
Indonesia, siap mengabdi nusa dan bangsa. Pertiwi tak pernah henti, Indonesia tercinta. Mellitus terus hebat, Indonesia sehat.
Thank you.
The next agenda is the Chief Executive's report, to be delivered by Yasvi Aulia Gustiawan. The stage is yours.
The Excellency, Director of Tasikmalaya Health Polytechnic Ministry of Health, Mrs. Dr. Dini Mariani, Bachelor of Nursing, Registered Nurse, Master of Nursing. Our distinguished speaker, Mr. Zhao Yuhin, Bachelor of Medicine and Bachelor of Surgery, Doctor of Philosophy, Assistant Professor at the College of Medicine, Ajman University, United Arab Emirates, and Visiting Associate Professor at Malaya University. Mrs. Dr. Aymeri Alfier-Barian, Registered Nutritionist, Dietitian, Doctor of Philosophy, and Associate at the Institute Human and Nutrition Food, University of the Philippines, Los Baños, Philippines. Mrs. Dr. Baizura binti Muhammad Yusuf, Doctor of Philosophy, Senior Lecturer and Clinical Dietitian at the Department of Dietetic, Faculty of Medicine and Health Science, University Putra Malaysia. Mrs. Suwin Mintas Purnamasari, Bachelor of Applied Science in Midwifery, Master of Health Science, Lecturer of Midwifery at Tasikmalaya Health Polytechnic, Ministry of Health. Mrs. Pepi Hapitria, Bachelor of Applied Science in Midwifery, Master of Public Health, Lecturer of Midwifery at Tasikmalaya Health Polytechnic, Ministry of Health, Cirebon Campus. The Honorable Head of Midwifery Department at Tasikmalaya Health Polytechnic, Ministry of Health, Mrs. Dr. Yati Budiarti, Bachelor of Applied Science in Midwifery, Master of Midwifery. The Honorable Secretary of Midwifery Department at Tasikmalaya Health Polytechnic, Ministry of Health, Mrs. Sri Gustini, Bachelor of Applied Science in Midwifery, Master of Midwifery. The Honorable Head of the Associate Degree Midwifery Study Program at Tasikmalaya Health Polytechnic, Ministry of Health, both Tasikmalaya and Cirebon campuses. The Honorable Head of the Applied Bachelor Degree Midwifery Study Program at Tasikmalaya Health Polytechnic, Ministry of Health, Tasikmalaya and Cirebon campuses. The Honorable Head of the Midwifery Professional Program at Tasikmalaya Health Polytechnic, Ministry of Health. The Honorable Coordinator of Student Affairs for the Midwifery Department at Tasikmalaya Health Polytechnic, Ministry of Health, both Tasikmalaya and Cirebon campuses. The Honorable all the invited guests who are willing to attend this morning and all the participants. Assalamualaikum warahmatullahi wabarakatuh. Good morning and peace be upon us all. By saying Alhamdulillah, let's say thanks to Allah Subhanahu wa Ta'ala. Because of His blessing, we can be present together in this space. May salawat and salam always be delivered to our Prophet Muhammad SAW, his family, his companion, and to all of us as his followers. This international webinar activity is held to help the healthcare worker, lecturers, students, and the general public learn more about an important health issue. As we know, stunting in children is a serious health issue in Indonesia. It not only affects growth, but also increases the risk of diabetes later in life. This webinar aims to address this problem through education and women empowerment. Alhamdulillah, as we can see today, approximately 1,000 participants joining on Zoom, consisting of students, lecturers, professional health worker, and the general public. The activity takes place on Friday, July 17, 2026 at 7 a.m. Indonesian time until finish, taking place in Zoom meeting. The objective of this activity include A. Explore the biological link between chronic malnutrition or stunting and the future risk of insulin resistance. B. Enhance early detection of gestational diabetes mellitus as a primary protection for fetal health. C. Smart parenting education to empower parents with knowledge of macro and micronutrient-based nutrition to reduce the risk of non-communicable diseases in children. D. Promote the use of Internasional health journal as a critical basis for promotive and preventive health education. The brief program full of this activity include: First, webinar opening. Second, material presentation and discussion. And last is our presentation and documentation. We hope through this international webinar, all the participants will understand the optimization of the strategic role of the healthcare professional in breaking the change of stunting and reducing the risk of diabetes mellitus through strategic evidence-based midwifery care during the first 1,000 days of life to achieve the golden generation of Indonesia 2045. As the organizing committee, I would like to express my gratitude to the university and the college who help and participate in this event. That concludes my remarks. I apologize for any imperfection. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you to our Chief Executive at this event for the report.
The next agenda, opening speech from the Director of Tasikmalaya Health Polytechnic, Ministry of Health. Please welcome Mrs. Dr. Dini Mariani, Bachelor of Nursing, Registered Nurse, Master of Nursing.
Okay, thank you. Can you share my voice clearly, everyone? Oke, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Can you hear my voice clearly, everyone? Please respond.
Waalaikumsalam warahmatullahi wabarakatuh.
Clear ya? Is it clear, guys?
Yes, clear.
Okay, thank you. Okay, very good morning and good afternoon and good evening to everyone joining us from different part of the world. Yeah. Distinguished speaker, respected college, honor guest, lecturer, healthcare professional, researcher, and a dear student. On behalf of Poltekkes Kemenkes Tasikmalaya, it is my great pleasure and honor to warmly welcome you to our international webinar entitled Golden Indonesia Begin with Smart Parenting, Managing Stunting in Children to Prevent the Double Risk of Diabetes Mellitus in Realizing a Healthy and Intelligent Generation. Today, we are united by a common purpose, of course, to explore how evidence-based parenting, nutrition, and healthcare intervention can build a healthier generation and contribute to a brighter future for our nation. It is especially encouraging to see participants joining us from different country and various professional background. Yeah, I see on the screen almost 1,000. I think. Thank you for all participants and for your attention to joining our webinar international today. Okay. It is actually encouraging to participant and our shared commitment to improving maternal and child health now. No boundaries today webinar is a wonderful example of how international collaboration can inspire innovation and strengthen our collective efforts to address global health challenges. We are deeply honored to welcome our distinguished speaker, whose expertise and dedication have made today's scientific discussion possible. Please join me in welcoming Dr. Zhao Mio Hein, PhD from Azman University, United Arab Emirates. Thank you. And Dr. Aime Ser, a Barian R&D PhD from the University of the Philippines, Los Banos, Filipina. Okay, thank you. And Dr. Nur Baizura, MD, Yusof from University Putra, Malaysia. Thank you. And of course, from international speaker, Bidan Wiwin Mintarsi, Magister of Public Health from Poltekkes Kemenkes Tasikmalaya, and the last speaker, Bidan Pepi Hapitria, Magister Public Health from Poltekkes Kemenkes Tasikmalaya. Thank you for generously sharing your time, knowledge, and valuable experiences with us. We sincerely appreciate your willingness to contribute to this international academic forum. Okay, ladies and gentlemen, every child deserves the opportunity to grow, learn, and thrive. Yeah. However, achieving this vision begin long before a child enters the classroom. Yeah. It starts within the family with informed parents, proper nutrition, quality healthcare, supportive communities, and strong public health policies. Stunting remains one of the most significant public health challenges, not only because it affects children's physical growth, but also because it influences cognitive development, educational achievement, productivity, and long-term health outcome. At the same time, the increasing prevalence of diabetes mellitus reminds us that nutrition and healthy lifestyle habit established during the earliest stage of the life can shape health across the entire lifespan. This is why today's theme is both timely and highly relevant. Smart parenting is more than raising children. It is about nurturing healthy habit, preventing disease, and investing in the future of our society. At Poltekkes Kemenkes Tasikmalaya, we believe the education, research, innovation, and international partnership are essential to preparing competent healthcare professionals who can respond effectively to today's complex health challenges. Through this webinar, we hope to strengthen academic collaboration, promote evidence-based practice, and encourage meaningful discussion that can be translated into real action within our communities. I encourage all participants to actively engage throughout today's session. Ask questions, of course, share your perspective, and learn from one another. Yeah. The exchange of ideas among experts, educators, practitioners, and students is what transforms knowledge into meaningful impact. Before I conclude, I would like to express my heartfelt appreciation to our distinguished speaker, moderators, organizing committee. We call it HIMA, yeah. HIMA from Midwife Department. Big applause. Yes. Okay, everyone, your present reflect our shared commitment to improving maternal and child health and building a healthier generation for the future. Let us remember that the journey toward a golden Indonesia and indeed a healthier world begin with every child, every family, and every informed decision we make today. May today's discussion inspire new knowledge, new insight, of course, and stronger collaboration and innovative solution that will benefit generation to come. Thank you for your kind attention. I wish you all a productive, insightful, and inspiring webinar. Wassalamualaikum warahmatullahi wabarakatuh.
Poltekkes Kemenkes Tasikmalaya is not merely an educational institution. It serves as a crucible for shaping the future health professionals who will occupy every sphere, respond to every challenge, and contribute across all dimensions of the healthcare sector. We are a hope for aspiring health practitioners who are prepared to meet the demands of a rapidly changing era. Founded with a spirit of service and commitment to health education, we have now advanced further, emerging as a center of innovation, collaboration, and transformation in the field of healthcare. Within an inclusive and dynamic academic environment, Poltekkes Kemenkes Tasikmalaya provides fertile ground where new ideas are cultivated, potential is refined, and the future of Indonesia's healthcare is envisioned. Students arrive from diverse regions, carrying aspiration and burning passion. At Poltekkes Kemenkes Tasikmalaya, those dreams are nurtured, and that passion is directed. Like seeds planted in fertile soil, they grow into individuals who are strong, intelligent, and compassionate. Our students are not only equipped with theoretical knowledge, but also trained to think critically, collaborate across disciplines, and adapt swiftly. They are future health professionals prepared not only to serve their nation, but also to compete on the global stage.
Assalamualaikum warahmatullahi wabarakatuh. Poltekkes Kemenkes Tasikmalaya is committed to producing healthcare professionals with noble character, professionalism, and global competitiveness. We continue to develop as a shining center of excellence, rooted in a combination of professional competencies and virtuous characters. This foundation equips our graduates to compete globally and bring positive impact to community worldwide. We have established ourselves as one of Indonesia's leading health education institutions. Our alumni now serve with high dedication, not only across the institute, but also on the international stage. At Poltekkes Kemenkes Tasikmalaya, we do more than educate. We shape the brilliant future of healthcare in Indonesia. Poltekkes Kemenkes Tasikmalaya, shine. Wassalamualaikum warahmatullahi wabarakatuh.
Poltekkes Kemenkes Tasikmalaya has extended its vision beyond national borders, embracing global outlook. We actively build collaborative bridges with leading universities, hospitals, and health organizations around the world. Through student exchanges, joint research programs, and internationally benchmarked curricula, we ensure that our graduates are not only competitive at the national level, but also ready to contribute meaningfully in global healthcare arenas. Our alumni have already established their presence across various countries, where their expertise is highly sought after evidence that the quality of our education meets international standards. Poltekkes Kemenkes Tasikmalaya proudly prepares its students to embark on a successful career journey with an extensive network of partnerships and a teaching factory system integrated with the global health industry. Our alumni serve as ambassadors of the nation, carrying Indonesia's name with pride. This is where global careers are born, from Tasikmalaya to the world.
Recording in
Thank you to
progress.
Mrs. Dr. Dini Mariani, Bachelor of Nursing, Registered Nurse, Master of Nursing for the opening speech.
All right, before we proceed to the next session, we would like to invite all participants to join us for a documentation session. We kindly invite our keynote speaker and all participants to turn on their cameras. Please smile and look at the camera as we capture this memorable moment together. Okay, everyone smile. For 1, 2, 3. For the next slide, smile. 1, 2, 3. Another next slide. 1, 2, 3. Next slide. 1, 2, 3. Another next slide. 1, 2, 3. Okay, everyone. Next slide. 1, 2, 3. Next slide. 1, 2, 3. For next slide. 1, 2, 3. Okay, another next slide. 1, 2, 3. Okay, thank you everyone for your cooperation. We hope this group photo will serve as a wonderful memory of today's event.
Dear participants, before we proceed to the main session, we would like to express our sincere appreciation and heartfelt gratitude to our fellow sponsors, BCA Bank, Sari Roti, Koperasi, and Kita Lulus for their generous support in making this event possible. Thank you to all of our sponsors for their generous support and valuable contribution. Your support has played an important role in the success of this event.
Dear participants, that concludes the opening session of the 2026 International Seminar of the Midwifery Student Association at Tasikmalaya Health Polytechnic, Ministry of Health. Now, we will proceed to the main agenda of today's seminar, which carries the theme, Golden Indonesia Begins with Smart Parenting, Managing Stunting in Children to Prevent Double the Risk of Diabetes Mellitus in Realizing a Healthy and Intelligent Generation.
Which will consist of presentations delivered by our 5 distinguished speakers. This agenda will be led by our moderators, namely Lazila Berliani Nur Hidayah, Nabila Putri Nur Armianti, and Devi Rahmawati Ihsan. We would also like to inform all participants that exciting door prizes have been prepared for those who ask the best questions during the discussion session later. Therefore, we encourage everyone to pay close attention to the presentations and prepare your most insightful questions. That's all from us. I am Fatia and my partner.
I am Teva, and for the first session is a presentation entitled Understanding Diabetes Mellitus, from Pathophysiology to Prevention Strategies in the Modern Era, such Pregnancy and Diabetes, to be delivered by Mr. Dr. Zhao Miao Hein, Bachelor of Medicine and Bachelor of Surgery, Doctor of Philosophy, that will be led by our moderator, Lazila Berliani Nur Hidayah. The stage is yours.
wabarakatuh. Good morning to our distinguished speaker, honorable guests, respected lecturers, and dear participants. Welcome to this Zoom meeting of International Webinar on Midwifery Student Association 2026. Tasikmalaya Polytechnic of the Ministry of Health. Presented by Team Golden Indonesia begin smart parenting, managing stunting in children to prevent babies of diabetes mellitus in realizing a healthy and intelligent generation. Thank you to the Master of Ceremony for giving me and allowing me to host this webinar session. I am Lazia Hidayah, and it is my honor to have an opportunity to be a moderator for this webinar session. First of all, let us say thanks to Allah who had given us blessing until we can gather in this place. Alright everyone, I will introduce our first speaker. He is Mr. Zhao Myohen, Bachelor of Medicine and Bachelor of Surgery, Doctor of Philosophy. Currently serving as an assistant professor at the College of Medicine, Ajman University, United Arab Emirates, and as a visiting professor at the Faculty of Medicine, University Malaya, Malaysia. And before we start discussing, let me read the CV of our first speaker. To the IT team, could you help me for sharing the CV? Dr. Zhao Myohen holds a rich background in medical sciences and international academic collaboration. He completed his medical degree, MBBS, in Myanmar, followed by a PhD in neuroscience from Mahidol University, Thailand. Currently, he splits his expertise across borders, serving as a visiting associate professor at University Malaya and an assistant professor at Ajman University, United Arab Emirates. He has also contributed globally as a visiting science at the Albert College of Medicine in New York. Dr. Zhao is incredibly active in the research community, particularly looking into neuroinflammation, the glymphatic system, and sleep-related brain mechanism. He has lectured substantial research grants and serves on the editorial board of prestigious journals such as Frontiers in Neuroscience and BMC Neurology. His dedication to academia has earned him numerous accolades, including the Faculty Excellence in Internationalization Award and the Best Student Research Supervisor Award this year. And I think Mr. Zhao already joined us right now. Excuse me, Mister, are you there?
Yes. Good morning.
Alright. How are you, Mister?
Good. Thank you very much for, bringing me here, having me here. It's my great honor to be in part of this prestigious webinar.
Okay. Oh, glad to hear you. That's really good, and thank you so much for joining us today. But Mister, before we start discussing, let me tell the audiences how the presentation will go. For the first, Mr. Zhao will present the material for 30 minutes, and after that, there will be a 10-minute for question and answer session, followed by conclusion. Alright, Mister, have you ready for sharing your experience and knowledge to us?
Sure. I'm really excited for that.
Alright. Okay, now, let's right away listen to Mr. Zhao present about understanding diabetes mellitus from pathophysiology to prevention strategies in the modern era such as pregnancy and diabetes. And please welcome Dr. Zhao Myohen, Bachelor of Medicine and Bachelor of Surgery, Doctor of Philosophy. The stage is yours.
Okay. Can you see my screen well and hear me well? Can you please confirm the master of ceremony, MC? Yeah. Okay. I will proceed. Good morning, everyone. I'm Dr. Zhao Myohe. I'm assistant professor from College of Medicine, Ajman University, United Arab Emirates, UAE. It's my very, very great honor to be here in this prestigious webinar to be part of the invited speaker. And thank you very much for having me here. So before I start my presentation, let me introduce a bit about like where I came from, where am I? So I'm from working in the Ajman here. So Ajman is like part of the United Arab Emirates. Basically, Ajman is the like one of the emirate where the United Arab Emirates belongs, near to Dubai. Okay, so I'm from Ajman, and then our university is one of the private first private university in Gulf region. And then this year, Alhamdulillah, we have reached the top 400, specifically 397 in the world ranking. Yeah, and then we have number 2 in the UAE for the international student, and then we have like lots of like international collaboration and rank number 6 in the UAE. So we have 9 colleges, and like medicine, dental, pharmacy, health sciences, nursing, physiotherapy program. Apart from the health sciences, we also have like other colleges for the engineering, business, law, and then mass communication. Okay, so let me talk to the specific topic of there today. So understanding diabetic. So from pathophysiology to the preventive strategy. So what is diabetic? What will be the underlying mechanism behind? These are the topic I'm going to cover, like why we need to study, why we need to know about the diabetic, and then like how the glucose homeostasis is going on, what are the pathophysiology, and then complication screening. And then since I believe like here the most of the audience will be from the nursing and midwifery background, I will cover a bit about the diabetic and pregnancy and then preventive strategy. So in this webinar, I'm not going to cover very detailed about the treatment plan, this and that. I will be approaching more to the like a public health approach, preventing and understanding of the disease pathophysiology. Okay, why diabetic? Why diabetic matter? What is diabetic? Okay, so why diabetic matter is like you see, as everybody know, diabetic is like one of the NCD, non-communicable disease, which is like around like 500 million worldwide affecting, and it really burdened the not just the patient, it's also the family, it's also the people living surrounding the patient. So why? Because like diabetes is like kind of silent killer, so it can lead to the like a major complication like a blindness, heart failure, kidney failure, and then like the other like a musculoskeletal disorder. And then it's also really affect the like not just the individual level, family level, country level, national level, it really affects. So that's why we need to know diabetes. As here you can see like a global burden. So globally, let's start from the like 2000 it was around like here 151 million estimated, and then now we are like around 2019, 2025, 26. So it's around like 400, and then between the 500. So this is like expected. So it is going to increase more and more. So that's why we really need to like understand the disease pathology and then prevent the diabetes. So globally, when we look at the data detail, so we are here from the Southeast Asia, you see, Southeast Asia going to increase more and more. This is from the like a WHO expectation. So diabetic will be more and more increase in the Southeast Asia compared with the other. For example, like the highest one will be here is Africa. In 2045, it will be increased around like 143%. But as also in Southeast Asia, with the expected population with the diabetes around like 153 million in 2045. So that's why we really need to understand the diabetes. So what is diabetes? So everyone know like diabetes is like, oh, high glucose, high glucose, high glucose. So the real definition of diabetes is chronic metabolic disorder. So what does it mean, chronic metabolic disorder? It's not acute condition. It does not happen like in one day. It doesn't happen like in 1 hour. It doesn't happen like in 1 week. So it has been acute, but normally patient don't know. We don't know until we detect. Okay, so that's a chronic disorder. That will be the increased level of the glucose. Why? There's a problem, defect in the insulin secretion or insulin itself. So can be the two reasons mainly, insulin deficiency or insulin resistant. So insulin deficiency is deficient, so there's no insulin. Okay, so inadequate production of insulin in our body. Insulin resistant, there's insulin, but our body is not responding to the insulin producing. So what does mean like we have a money, we don't know how to spend the money. Okay, so we have a what do you call the glossary? We don't know how to cook the glossary. So here are the type of the diabetic summary. So we have like type 1, type 2, gestational type, and then there are some other miscellaneous type. So type 1 is like mainly insulin deficient. Insulin can be deficient, can be sometimes like type 1 congenitally, or maybe sometimes like immune mediated. That's just a summary. I will tell you more detail later. Okay, and then like type 2 is like insulin deficient. So that cell producing insulin, they are not functioning properly, so dysfunction. Another type we call the gestational diabetes. This is that's only during the pregnancy, but this is also very, very important because like in the future, that mother with the gestational diabetes, they can have a full-blown diabetic later. So how does our like a glucose system going on? Okay, so when we eat the food, what will happen is when we eat the food enter the body, so there will be there, what do you call that? Carbohydrate, glucose, sorry. Okay, that glucose will enter the bloodstream. At the time, the body starts stimulating the pancreas. Pancreas will start releasing the factor called the insulin here. Okay, so that insulin will go down to the blood, and then it will start insulin at the target organ, the muscle, liver, and then fat. So that insulin promote the glucose to put into the cell here. So now our body has the glucose, and then that glucose will be maintained at the balance state. So in this case, like this glucose, homeostasis having broken down. So what will happen is, like if it is broken down, what will happen? There will be the hyperglycemia. So that's why after eating, the blood glucose rise. At the time, insulin will release, and then like that insulin will help the muscle, liver, and fat cell, to take up the glucose into the back to the normal. So this is the normal homeostasis. Okay. So what is the pancreas? So inside the pancreas, we have like a different type of cell: alpha cell, beta cell, delta cell, and then PF cell. So major cell, which is playing role for the with the what do you call the glucose and insulin, is the beta cell. So actually, beta cell from the islet of the pancreas is like only 1 to 2% of the pancreas, that islet cell. So that islet cells are mainly for the insulin, and then so what they do, they decrease the blood glucose level in the blood, and then they promote the glucose uptake, glucose uptake from the, and then it's also like a store as a glycogen. So glycogen will be like our storage for the future, like if we need in the future, like for the, what do you call the energy storage. So of course there are the other cell like alpha, delta, they also involved in the glucose homeostasis, not like importantly like insulin. Okay, so these hormone work in all the coordination and manner to maintain the like a glucose homeostasis. So in the overall metabolic balance will be balanced. Okay, so and then we have an insulin. So that insulin has to be accepted by the insulin receptor. So that insulin receptor will be processing. Finally, they will promote the blood vesicle, to the GLUT4 receptor. So why I am telling you this is like nowadays, future direction for the drug therapy. Nowadays, future direction therapy is all depend on this molecular signaling. But I mean, like as a healthcare worker, of course, like we don't need to know detail about this all mechanism, but like all the nowadays new generation of the drug are depending on this all signaling pathway and mechanism. So what happened? So this mechanism should be properly working inside the body. So for example, as I show here, this is the normal insulin signaling. So insulin will act on the receptor, will promote the receptor, will add on the glucose cell, and then they will uptake the glucose. So glucose will be within to the cell, not to the blood. So, but in case of insulin resistant, there is an insulin, but that insulin is not working properly. So for example, inflammatory reason or the other congenital reason. So in this case, but we have an insulin, but that insulin is not using properly. For example, like inflammatory disease, SLE or the other problem, Crohn, there will be the insulin, but insulin is resistant. So at the time, this receptor has been like a, reduced level, and then at the time they are not working properly. So what happened is like there will be hyperglycemia. Here I have highlighted that insulin resistant is like not just again like acute state. Insulin resistant may begin from the 10 to 15 year before patient has been diagnosed as a full-blown diabetic. So especially for the patient with the obese central obesity, patient are like, oh, okay, obese is like normally obesity is like insulin resistant. So fat cell, a lot of fat cell here. So there will be like a, what you call they will be not, favoring to the, proper working of the insulin here. So that's why if we have a edible tissue fat, so fat, fat, we have a different fat, a subcutaneous fat and then visceral fat. Subcutaneous fat mean like if the fat just underneath your skin, so that was like a low risk, but visceral fat mean like the fat stay inside the visceral. So the fat stay like the fat stay between your intestinal organ, like a liver, stomach. That's why fatty liver is one of the very, very important, common metabolic disease related with the diabetes. So, so visceral fat, we need to try to reduce the visceral fat level. So by why? By doing a lot of exercise, reducing the fat intake. Why this visceral fat are the high risk factor? So metabolically, they are very dangerous for the coronary heart disease and this and that. So how does it happen? So one, we eat something, our glucose level will be climb up. So at the time, body will stimulate because there will be the stimulation to the beta cell. They will release the insulin. So that insulin with this from here, high glucose level, they will produce the glucose level, and then they will promote their glucose into the cell. At the time, also glucagon will release, and then glucagon will store some of the glucose as a glycogen in the liver for the storage. So this is the normal cycle. In like a kind of disruption of this cycle, there will be no balance of the glucose anymore. There will be the hyperglycemia. Okay. So sometimes it just not between the the glucose and then pancreas. Sometimes like especially in type 2, like so hyperglycemia, they affect like increase HB liver, and then it's also disturb the because whatever we eat have to be degraded and metabolized by the liver and then excreted by the kidney, right? So excess glucose will be filtering to the kidney during the the urine, in the urine sample. So like this glucose metabolism is like this outtake pathogenesis, mean like it affect the including insulin secretion, it affect the a fat cell, it also affect the brain cell, because some studies show because it's already confirmed chronic long-term diabetes is have a very, very significant relation with the a kind of brain Alzheimer disease. Okay, so what are the classification? So we have, as I mentioned, introduced in the earlier before, we have type 1, type 2, and then the other miscellaneous, MODY, ladder, and then GTM. So what is type 1? So type 1 is basically there's an insulin insufficiency. So autoimmune beta cell dysfunction, autoimmune can be immune region, or sometimes, there are many studies that in many cases reported during the COVID, after the COVID, because of the COVID itself, virus attack, or after the COVID, we try to get the immunization, right? So at the time, vaccine related, there are lots of cases reported diabetes. So type 1 is basically insulin deficiency. There's no insulin. So simply saying the treatment should be insulin replacement. But type 2 result from the progressive insulin secretory defect. Insulin secretory defect mean there is there might be the proper insulin will be there, but there's no processing. There's proper insulin there, but sometimes that insulin is not using properly. So progressive insulin secretory defect So, and then this is called the insulin resistant. So insulin is there, that insulin has been resisting to promote, to use it. So clinical presentation of the type 1, normally type 1 is full blown, symptomatic. So there was patient will start with the like a hyperglycemia is very common. Sometimes, you know, for the sometimes type 1 start with the early age. So type 1 failure to thrive. So patient, we will start noticing sometime one very late, the patient will cannot failure to thrive or cannot grow properly compared to the other kids. And then sometimes just mild symptom is like a hyperglycemia. So at the time we will not notice anything, you know. So and then also like age of onset is typically around first 2 decades. First 2 decades mean like around like 10, 20, you know. But sometimes it is type 1. If it's not very severe, it will be late notice and then late diagnosis only at the early age. So this is like sometimes confused with it can be mistaken with the type 2. So basically type 1, if you don't know, that can be there. It's symptomatic, typically, especially what kind of type, like late onset autoimmune types, you know. And so that's why I said like it can be misconfused with the misunderstand with the type 2. So there can be like other like LADA, late onset, and then we need to aware of that. So clinical presentation, sometimes type 1, we don't know. There's a, because type 1 is present at the early age, right? So we don't know. Sometimes type 1 come to the hospital only as an emergency, like a coma or severe like other stress condition. So at the time, insulin replacement is the main therapy. So symptomatic, but not immediately. So that's why like what happened is like diabetes is like preventing some year only any intercurrent stressor. So we need to be carefully treating pharmacotherapy if we need like early intervention, not just for the insulin, the other, whatever the comorbidity we need. Sometimes it's symptomatic. That's why the patient will be diagnosed only the screening or incidental symptom. Okay. So, and then subclassification. The other subclassification, MODI. MODI means like maturity onset of diabetes. So when they become mature, they will be notified. It's like kind of milder form, MODI is, but like it's more stable. And then they have a like a not very like a high glucose level, like 400, 300. It will be like mild hyperglycemia, sometimes asymptomatic. So MODI can be, that type can be because of the genetic. So there are a lot of genetic factors influencing, involving in the beta cell dysfunction. So that's why this MODI is one of the causes is the genetic cause. The other is also like a, you know, autosomal inherited if they know like before the age of 5. So MODI can also be like depending on the different type. So this is like advanced level. So you can do like gene sequencing and you can even identify like what kind of gene involved there, like, you know, HNF4 gene or GCK genes. So, but because nowadays, I mean, precision medicine is like targeted to the specific gene therapy. If you know properly the exact gene, you can replace the gene replacement therapy. You know, MODI type 3, which is the commonest form in the young, genetic form, and then, and this because of the HNF1, but subtype you see, MODI type 1 is 4A gene, MODI type 3 is a 1A gene here. Okay, another one is a LADA. LADA is a latent autoimmune diabetes. So it is only diagnosed, it's latent, but it's autoimmune, but it's latent. So autoimmune means it belongs to the T type 1. But like it's latent, so that means like it has been late, you know, late. So it will be diagnosed only after the age of 30. So the test we normally use for this one is like there's like antibody test. We can use the glutamate acid decarboxylase, which is a diagnostic marker. And then in the presence of the antibody, so that will be attacking to the pancreas, but it's like not very full blown. So in this case, so their thing is like antibody, right? So normally here in this case, like if we normal drug like sulfonylurea, you know, like a metformin, they are not really recommended. So they need to have a specific GLP-1 inhibitor or DPP-4 drug, so that can help to the beta cell function to come back properly. Okay, so how shall we diagnose? How we will know what is the diagnosis value? Okay, so let's memorize together. Like, okay, diagnosis is like a 7-11, 6.5. You know the 7-11, right? I hope you have 7-11 in Indonesia. It's like convenience store. So 7-11, 6.5. So what is 7-11? So diagnosis, random glucose, fasting glucose, more than 7 millimole per liter. So some country, they use the milligram percent, the same. Okay, so random plasma, random, anytime, you do the blood test, 11.1 millimole per liter is above 11.1. This is a red flag. But if you found the patient for like during the screening or during the antenatal care, you know, if you found the patient random blood glucose 11.1 above, So you need to do the fasting again. Fasting means like at least patient have to take the avoid the calorie for like at least like 8 hours. So fasting 7 and then 11 mean like a random plus glucose level is more than 11, 7, 11. And then sometimes if special case like maybe like gestational age diabetic, we need to do the OGTT test. And then after 2 hours postprandial, it is more than 11. That is mean we can be diagnosed as a diabetic. Okay, what is the diagnosis plan? We will do the screening. Firstly, we'll do the screening. Is there any sign and symptom of hyperglycemia? Okay, if it is like a yes, there's a symptoms of hyperglycemia like polyuria, polydipsia. Okay, so we will do the single random plasma. Okay, if it is more than 200 here, I'm telling you with the milligram percent. Okay, more than 200 milligram percent is a diabetic. Okay, otherwise, if there is a single, and then we can do the fasting or 2 hour. Okay, this is like there's patient with their symptom. Okay, if there's no patient with no symptom, patient, if the patient is obese plus one or more risk factor of the diabetes like family history, like a sedentary lifestyle, lack of exercise, those kind of things. If the patient has those factor, okay, no. If a patient is like more than 35 years, no. So okay, no need. If a patient doesn't belong to this or any category, okay, no need. Just wait until the symptom get. Otherwise, okay, patient have the risk factor. Okay, we'll do the fasting, or we can easily do the more accurate test, HbA1c. Okay, so for HbA1c, cutting point is more than 6.5. Okay, this is the full-blown diabetic. 5.7 to 6.4, this is pre-diabetic. So what does it mean pre-diabetic? This patient has a very high risk of having diabetes in the future. So lifestyle modification seriously should be done. If not, patient will have a diabetes in the future. Or HbA1c level is less than 5.7. So it's healthy, but healthy, we cannot leave him alone for forever. So what we have to do is repeat the test, confirm the test again, maybe every 6 months or 3 months. Okay, next. If the patient has a risk factor, and then glucose, we do the fasting glucose. Fasting glucose is more than 126, and then OGTT more than 200. Okay, class, this is the confirm, is a diabetic. Okay, otherwise like a pre-diabetic value for fasting here is with the oral glucose level is here 100 to 125. OGTT is 140 to 199. And then if the patient is below fasting, below 100, OGTT below 140, okay, this the patient is healthy. As I told you, this healthy comes from here, obese patient with a risk factor. So that means he or she is still not safe. You have to follow up like every 6 months or 3 months. Okay, so this is the most important slide in my PowerPoint. So that's why here early detection and screening are very, very, very helpful. So early detection for who? Healthy adult, and how? Healthy adult every 3 years after the age of 35, according to the local guideline, because sometimes, our genetic factor and then it's really affect. So people from the Africa, they have a different body structure and then body build and then different glucose mechanism. So overweight plus risk factor, we need to do earlier screening. And then pregnant women will be start doing around early second trimester, or if it is first trimester, the best. Okay, previous gestational diabetes mellitus. Or patient with their previous pregnancy, pregnant mother has a history of gestational diabetes. So they might have a lifelong diabetics in the next few years. So that's why every 1 or 3 year screening. So as I told you, diabetic is a kind of silent killer. Sometimes most patients, they don't have a symptom, So that's why in this case, early diagnosis, prevent the irreversible complications, stroke, and then amputation, cardiomegaly. So what are the complications and how shall we do screening? Complication, we have acute complications, acute attack of the hyperosmolarity, coma, this and that. And then there can be the chronic complication. So chronic complication, that will be macrovascular, microvascular. Macrovascular, they affect the big vessel from the heart, from the heart, cardiac, or there will be the atherosclerosis, and then cardiovascular, and then peripheral, not just a heart, peripheral vessel, vessel in our other part from the heart, they will affect like atherosclerosis, and then this artery leading to the pain, and then sometimes ischemia. So ischemia means like there will be no more blood supply, and then cerebrovascular disease, which can lead to the ischemic stroke or TIA, transient ischemic attack. And then small vessel, mainly they affect the retina or the eye. So retinopathy, what does it mean? Like it will damage the like retina micro vessel. So sometimes diabetic complication is like it can lead to the blindness if the patient doesn't monitor the patient is not doesn't monitor carrying the glucose level properly, is not taking any proper what do you call the medication and treatment and guideline, so they can lead to the blindness. And then nephropathy as one of the other common complication. So as I told you, excess glucose will be secreted from the kidney in the urine, so the patient will have there will be like a increased level of the glucose that will damage the kidney. And then finally, the kidney cannot do the filtering function. The kidney will start losing the protein. So proteinuria. In the chronic case, there will be the proteinuria. And then neuropathy, nerve damage itself. So sometimes nerve is like not just a sensory nerve, then the autonomic dysfunction, it will lead to the like abnormal heart rate and then like arrhythmia. So sometimes because of the combine mean like this microvascular and microvascular combination. So there will be like a improper blood flow, ischemia, diabetes, and then like erectile dysfunction in male because of the nerve neuropathy, nerve function dysfunction. Okay, so this is again like a summary. So again here, diabetic neuropathy is like one of the leading cause of blindness, as I told you, even in the adult working age. So which is really a danger, So this is one of the common reason diabetic neuropathy, which can lead to the blindness. And then 2 to 4 for increase of the cardiovascular mortality. So patient compared with the other patient having the diabetic has like a 2 to 4 times increased chance of getting the stroke. And then diabetic nephropathy is one of the common cause of the end-stage renal disease, and then like foot ulcer, amputation. These are the other complications. Okay, diabetic nephropathy. So nephropathy is more common with like a type 1. Why? Because type 1 they develop earlier. That's why 35% with the type 1, and then type 2, 20%. And then if the patient is like other associated condition, high blood pressure, smoking, and then like a high LDL level, so that will be more prevalent. So this is one of the symbol. Sometimes diabetic alone can lead to the end-stage renal failure. So like end-stage renal failure, I mean like it's the end. So the kidney is totally not functioning anymore. I mean like there's no other option. I mean even like sometimes renal dialysis cannot happen. So renal replacement therapy, or sometimes albuminuria, then proteinuria, because albumin and protein, like albumin is like smaller protein. So that's why nowadays when we do the screening test, we do the microalbuminuria. We start detecting the small protein before the big protein size are leaking. So what happens is like protein are losing from the body. Protein maintain the osmotic pressure inside the body. Patient will have edema, and then finally loss of GFR, and then progressive loss of the renal function. The other histologically, there's like because of the long-term diabetes, there can be the glomerular fibrosis, and then intestinal fibrosis can happen. So how shall we do the screening for nephropathy? Normally we do the creatinine and GFR, and then also we calculate during albumin to the creatinine ratio. So in this case, we have to do the like creatinine every 3 months or 6 months, and then also the microalbumin in the urine every 3 months or 6 months. So this is one of the screening tests to detect the nephropathy earlier. Sometimes in the case like a patient have a what do you call the patient have a okay, thank you. Patient has like a kind of albuminuria. We can calculate that if it is like to confirm the diagnosis. We have to do like 24-hour urine collection. I mean, for the retinopathy, there's like a different type, non-proliferative. Early stage we call the non-proliferative. So it's not like just a micro small aneurysm there, but early stage, so it doesn't affect the what do you call the blindness, but at the late stage it will affect the more proliferation, and it will affect the blindness. So like this is the why. So that's why what do we normally do is like fundoscope. Looking at the fundus, there's a normal fundoscope. When you compare with here, there's a progressive stage. There will be like more vessel engorgement, and then here diabetic retinopathy is already damaged the retina. This other edema versus swelling inside the fundoscope. Okay, so retinopathy, what shall we do? We have to do annually. So for nephropathy, we have to do like every 3 months, 6 months, creatinine and albumin. For nephropathy, we have to do every annually fundoscope monitoring, and then also for the proliferative disease and even all those in the pregnancy. Okay, so next is a neuropathy. So neuropathy is like around 50%. So it's also high chance of developing the complication. Okay, so that can be the peripheral, and then also the single nerve. Sometimes it affects only specific nerve. So the patient can present with the like a cranial nerve defect. Cranial nerve mostly affect the 3 or 4 or 6 or like a 7. And next is the diabetic neuropathy. So because of the diabetic autonomic neuropathy, it's like defect in the autonomic nervous system. So autonomic nervous system is mostly closely related with the heart. So there will be like posterior hypertension, there will be abnormal heartbeat. So, and then there's no proper blood flow that can lead to the erectile dysfunction sometimes. Autonomic nervous system supply the GI tract, right? So diabetic patient, they have a constipation and then sometimes diarrhea. Sometimes like a hypotonic bladder, they cannot go to the bathroom properly, So these are the symptoms, but we have to be careful present of this symptom. If the patient has this symptom, that means like patient has been experiencing diabetic more than 20 years ago. The other is a diabetic foot and diabetic ulcer. So there's the instanic ulcer, they are sometimes small ulcer, and then sometimes it will become like a bigger and bigger, and then it will be the infection. So this is because of the involvement of the individual small peripheral nerve. Okay, other complication, as I mentioned in the earlier, so not just the nerve, not just the organ, there can be the musculoskeleton, So if you're trying to contracture, or here we have a thenar muscle atrophy, carpal tunnel syndrome, because this muscle is supplied by the specific median nerve. So diabetic, long-term diabetic, there is the neuropathy of their median nerve. Sometimes patient will have like a shoulder pain, capsulitis. So patient will come to your clinic to see you as like, oh, I cannot do the combing, I cannot raise my shoulder. This is the shoulder capsulitis. So general management plan, type 1, insulin need, we have to replace the insulin. Type 2, normally it doesn't require the insulin at the early day. So what you have to do, you have to just give the drug that will promote the insulin functioning. And then very, 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 very important thing is type 2 is the lifestyle advice, like exercise, diet. And then whenever you see the type 1 and type 2, you have to do the screening. So let me cover a bit about the diabetic in pregnancy. So why we need to do the diabetic in pregnancy, like preconception, diabetic. So patient already having the diabetes in long ago, so they can lead to the congenital anomalies, So gestational diabetes is like nowadays worldwide, and then it's like 1 in 6 pregnancy. So that's why. And then patient with the diabetic pregnant mother has a more chance of preeclampsia, and then it's leading to the cesarean delivery, and then there will be like polyhydramnion, and then fetus, there can be the fetus with the like complicated anomalies fetus. Okay, and then that gestational diabetic mother can have a later, after many years later or few years later, they can have a diabetic, and the patient can, the children can also have a diabetic in the late. So what shall we do? The screening test. This has been already covered a bit before. So diagnosis test, we will do the OGTT, and then we'll do the HbA1c. Normally nowadays, we don't recommend the random glucose test. Better you do the fasting or A1C or OGTT. Okay. So here, this is the guideline. So early day, first prenatal visit. Okay, high risk patient, no. Okay, just follow up, do around like a 24 to 28 week, do the OGT. If it is high risk patient, yes. So they will do the post glucose, A1C, and then random glucose. If the level is more, okay, we will confirm this is the diabetic. If the patient, sometimes, you will miss the patient at the early day. If the patient come around like a second trimester, so the glucose tolerance that you do, and then if it is normal. If it is like gestation, these are the value for the gestational diabetic. So it's a little different from the regular diabetic. And then if the fasting is more than 7, so there is a full-blown diabetic. Okay, so normally management plan is like, firstly, what you have to do, you have to refer to the specialist or doctor, tertiary center. And then normally is insulin. Some countries, they still use metformin. It's a controversial depending on the availability. But at the same time, as I mentioned, preeclampsia is very common. That's why you need to check their blood pressure, or maybe also the ultrasound scan for their baby, because like congenital anomalies are very common. And then delivery, we aim at the 38 week.
remaining.
Okay, thank you, Ambi. So postpartum follow-up, like you need to do breastfeeding, and then weight monitoring, the other. Okay, lifestyle modification. So how we will prevent this is lifestyle modifications, like physically more than 10 minutes per week, and then increased fat intake can lead to the diabetes, right? So that's why we need to reduce the weight and then start reduction. So this is the evidence base, like if you your physical activity is like 150 per minute per week, you can lose your weight. You can lose your weight around like 5 to 7%. So that will lead to the reduction of the diabetes risk by 58%. Older people also has affecting this. So what shall we do? What shall we avoid? So lack of exercise, you are just watching the like TV from the sofa. These all are leading to these all habits you have to avoid there. At the same time, smoking, because that will also increase the cardiovascular risk factor. And if you have a symptom, not just a hyperglycemia, and then the other like heart-related system, you have to be careful, because like your body is like something wrong, something happening, so you need to avoid. Okay, so finally, this is my last slide. Do every 30-minute walk, and then eat more veggie, and then fruit, and like try to sleep around like 7 to 8 hours, at least like 6.5 and 7, and then try to manage the stress. Okay, and then do the regular checkup, which is very, very important. So this is the take-home message. So diabetes is not just diabetic; it does happen with a complex disease, governed to the metabolic and other like vascular disease. So insulin resistant and insulin dysfunction, and then chronic hyperglycemia can lead to the other macro and micro complication. So lifestyle modification is the main goal than the drug. Yeah, thank you very much. I hope I finish in like the right time.
Alright. Now we will move to the question and answer session. If you want to ask, you can write it down in our chat room, or you can click the raise hand button. So tell your name absolutely and tell your question. Alright, mister, will the question answered immediately, or will they be collected first? I got the first question. For the first question is from Ismi Aulia. I welcome Ismi to tell the question.
Okay, excuse me, Mr. Zhao. My name is Ismi Aulia. I'm a midwifery student at Poltekkes Tasikmalaya. I would like to ask, in the modern era, where the prevalence of diabetes continues to rise, so what prevention strategies are most effective for women of reproductive age before and during pregnancy? Thank you.
Okay. Thank you very much for your question. Yeah. So for women at the reproductive age, the preventive measure should be like, firstly, she is as a risk or not. Risk factor means she has a family history, or like she has other comorbid disease or not. Okay. The guideline I show you. So if it says no risk factor, if she's concerned, we are talking about the prevention. Prevention even before pregnancy, healthy lifestyle, like regular exercise, and then also like low glucose, low calorie diet. Okay, so during the pregnancy, early day, if it is like this is sometime nowadays very, patients are very like cautious. Sometimes they do the pre-pregnancy counseling, come to the doctor or go to the midwife to do the pre-pregnancy counseling. Oh, we are planning to have a conception. So is it good to have a conception or not? At the time, if possible, better do the just random blood sugar test. Okay. So if it is normal, just follow the other like antenatal screening, inshallah. Oh, okay. If it is not like that, so you have to do the fasting again and then follow the guideline. Okay. For the prevention is like just a healthy lifestyle, exercise, eat veggie more, and then fruit. But regarding the fruit is good for the health, but patient with the diabetic, fruit is like limited because some of the fruits are very high calorie and sweetness. So preventive measure is according to the guideline. So you follow the like a firstly screening, and then you can follow the like other antenatal care. It's lacking. That's a very good question from Ita Nur Fitra. Walaikum salam. See, I totally agreed. The question is like, although the educational about the gestation of diabetes is routinely provided during the antenatal care, incidence of complication remain high. Do you think current educational approach are sufficient, or we should be redesigned? Okay. So I mean, redesigning this and that's it. Firstly, okay, I will talk about the what do you call incident is high. Incidence is high mean like early intervention. We need to have an early intervention, and then we need to be well prepared. That's why I mentioned during the antenatal period. Okay, when this is the gestational diabetes, you have to have a close monitor of the patient. You have to have a close monitor of the patient. Like what? Because they can be there. They can have a preeclampsia. They can have a anomalies, baby. So in case of like close monitoring, for example, regular ANK is like 2 weeks later, 4 weeks later. So in this kind of patient, gestational diabetes, we have to close monitor more frequently. And then if there is like any abnormality happen, we will have a proper early intervention or early referral. Of course, optimal, we aim to deliver at inshallah 38 weeks, but in case sometimes we have to judge, so keeping this baby inside the uterus is like life-threatening for the mother or life-threatening for the baby. To prevent the complication, sometimes we deliver earlier. So it also depending on the facility you have. So according to your question, I think current educational approach are sufficient or need to redesign. I think educational approaches, inshallah, should be fine. For me, like you need to, in this case, like not just the primary healthcare level, also the nationwide program, I think if redesigning is like, nationwide program, government level, public health sector, they need to involve.
Sorry to the participant who want to ask, but because this question and answer session is only 10 minutes, we want to move to another session. Alright, thank you for your amazing explanation, Mr. Zhao. The question has been answered. Okay,
if they have any other question, they can email me. Okay, I will be happy to reply. Thank you very much.
Okay. Thank you, Mr. Zhao. Okay, everyone, we will end this session. Allow me for the conclusion about our discussion today. From the insightful presentation delivered by Dr. Zhao Myohin, it can be concluded that while diabetes mellitus remains a rapidly growing global disease affecting over 530 million people, we are far from powerless against it. The core of the material reminds us that effectively tackling this condition relies on precise pathophysiological understanding and early screening, especially during critical windows like pregnancy. Ultimately, the most empowering takeaway is that type 2 diabetes is highly preventable through simple daily choice like staying active, eating mindfully, and resting well. It is our sincere hope that today's session serves as a turning point for all participants. May we
Recording
leave this
stopped.
webinar not just with deeper knowledge, but with the inspiration to truly listen to our body's early whispers, taking proactive steps today to secure a vibrant, healthier tomorrow for ourselves and our communities. Finally, now we have reached the end of this session, and I would like to say thank you to Mr. Zhao as our first speaker for the great webinar, and also to the audiences for their active participation. We got a lot of knowledge from here. Mr. Zhao, we have a certificate for you as appreciation as a speaker. To the IT team, could you help me for sharing the certificate?
Recording in progress.
Okay, before we end the session, maybe we could take some picture together, Mister. Right, Mister. Here is the certificate of appreciation from us. May it serve as a meaningful recognition for your contribution. Okay, everyone, open your camera and give your better smile. To the IT team, could you help me for screenshot this picture? Okay, we can screenshot in 1, 2, 3. Oh, that's really good. Improve our screen session. Alright, now we've done to take some picture together. And I would like to once again express our deep gratitude to Mr. Zhao. It has really been a wonderful opportunity for us to have this discussion.
Recording stopped.
Thank you so much, Mr. Zhao, and we hope you always stay healthy and happy.
Thank you very much.
Last but not least, I would like to extend my appreciation to all of us for learning together in this occasion. May you always happy even after joining this webinar. May you always happy even during this webinar, and please give applause. Finally, I am Lazila Hidayah as the first moderator as for LIP. We will move to another session, the next moderator, Nabila Putri Nur Armianti. The stage is yours. Thanks to Lazila Hidayah for leading me to lead this session. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome to the Zoom meeting of International Webinar on Midwifery Student Association 2026, Tasikmalaya Polytechnic of the Ministry of Health. Present by team Golden Indonesia begins with smart parenting, managing stunting children to prevent boundaries of diabetes mellitus and realizing a healthy, intelligent generation. I'm Nabila Putri Nur Armianti. It is my honor to have the opportunity to be moderator for this webinar. First of all, let us say thanks and pray to Allah Subhanahu wa Ta'ala for giving us the grace of health and safety so that we can gather in this webinar happily. Okay, everyone. I will introduce the second speaker for today. She is Dr. Aini Shiri of Barbarian, registered nutritionist, dietitian, doctor of philosophy, and associate professor at the Institute of Human Nutrition and Food, University of the Philippines, Los Banos, Philippines. Before we start discussing, let me read the CV of our second speaker. To the IT team, could you help me for sharing the CV, please? Okay, it is my pleasure to introduce our next speaker, Dr. Aini Shiri of Barbarian, RN PhD, who serves as Professor H at the Institute of Human Nutrition and Food, College of Human Ecology, University of the Philippines, Los Banos, UPLB. She resides at 10,113 Sierra Madre Street, Umali Subdivision, Barangay Batong Malaki, Los Banos, Laguna, Philippines. Dr. Aini earns her Doctor of Philosophy in Food Science, Master of Science in Applied Nutrition with a minor in Microbiology, and Bachelor of Applied Science in Nutrition from the University of the Philippines, Los Banos. She is a registered nutritionist dietitian and completed her secondary education at the University of the Philippines Rural High School. With more than 3 decades of experience, Dr. Aini has built an outstanding career in teaching, research, academic leadership, and nutrition services. In addition to her role as Professor H at UPLB, she has held several prominent
Recording in
positions,
progress.
including Director of the Institute of Human Nutrition and Food, Associate Dean of the College of Human Ecology, Editor-in-Chief of the Journal of Human Ecology, and Chairperson of the CHED Technical Panel in Nutrition and Dietetics. Her expertise covers food science, nutrition, food safety, and public health. She has authored and co-authored more than 67 scientific papers published in national and international journals, and has presented her work at numerous international conferences. She has likewise been actively involved in various research projects, scientific collaboration, extension programs, and professional organization. Her dedication has been recognized through numerous national and international awards, scholarships, and academic honors, as detailed in the CV. Okay, I've now read the CV of Dr. Aini, and I think Dr. Aini have already joined us right now. Excuse me, miss, are you already with us?
Good morning.
Okay, how are you today, miss?
I'm doing good. Thank
Very
you.
glad to hear that, and thank you so much for joining us today. Before we start discussing, let me tell the audiences how the presentation will go. For the first, Miss Aini will present the material for 30 minutes. And after that, there will be a question and answer session for 10 minutes and followed by a conclusion. Okay, miss, have you ready to delve for today's material?
Yes, allow me to share my screen.
Okay, now let me listen to the material that will be presented by Dr. Aini about pregnancy and diabetes, early detection, clinical management, and protection for the first generation. And please welcome Dr. Aini of your Barbarian and PhD. The stage is yours.
Okay, thank you very much. Good morning, everyone. So I would like to thank the Midwifery Student Association. I would like to also greet the director, Dr. Dini Mariano Esquep. So good morning to all the faculty and staff of the university. Thank you very much for inviting me over and allow me to share my knowledge on the topic on stunting as a registered nutritionist dietitian in the Philippines. So let's get into it. The learning outcomes for today's session are as follows. Understanding that stunting is not just a height issue, but also a biological, developmental, and societal concern that shapes a child's future health, learning capacity, and economic development. Let me emphasize that maternal nutrition is the single strongest determinant of fetal growth and therefore central in preventing stunting. When learners understand maternal nutrition, they will know how the mother's health becomes the child's lifelong foundation. We will also discuss the relationship of stunting and type 2 diabetes and identify preventive actions, particularly antenatal care. Let us now delve deeper into the concept of stunting. Why is it important and why it matters a lot? Stunting is a biological signal that a child has experienced long-term undernutrition during the most critical periods of growth, starting from conception, especially during the first 1,000 days. When a child is stunted, it means that the body and the brain did not receive the nutrients, protection, and care needed to grow to full potential. It is not just about the height. To situate our discussion, let me share a short clip from WHO that frames stunting from a global perspective. Stunting hinders development. How? By impeding physical and cognitive development. It reduces the productivity potential of an individual. The negative consequences of stunting cannot be overemphasized as we deal with its rising prevalence and targets to reduce its number are actually not met. Let us look at the numbers from some countries recently. Stunting, defined as low height for age due to chronic malnutrition, affects nearly 1 in 4 children under 5 in the Philippines, with a prevalence of around 23.6% in 2023, according to UNICEF and the Food Nutrition Research Institute data. It's down from 33.4% in 2015, but actually still high compared to countries at similar development levels. Recently, the Philippine Star, a local newspaper, reported that child stunting in the Philippines jumped to 25% last year in 2025. It's the first increase in a decade, according to the government nutrition data. This actually means that out of every 100 Filipino children under 5 years of age, about 25 are stunted, meaning they are too short for their age because of chronic malnutrition. We are way out of the global nutrition target of reducing stunting by 40% by 2030. That is 4 years away. And this is actually just a recent publication of the National Nutrition Council, July 9, just last week. So they publicized an alarming call to really take action in terms of the rising prevalence of stunting in the Philippines, actually also obesity. The 2025 target has not been met. Number of stunted children under 5 years of age dropped from 177.9 million in 2012 to around 150.2 million in 2024, with Asia having 51% of the global share and Africa 43%, based on data from WHO UNICEF. There are successful campaigns in other parts of the world like Nepal and Peru. In Nepal, a multi-sectoral nutrition action plan was developed to address the undernutrition problem. The multi-sectoral interventions included health, agriculture, education, local government units, and also urban development units. The government efforts to train health staff, educate the caregivers, improve the economic situation of the family, and increase health facilities significantly reduce the number of undernourished children. Almost the same case in Peru, where the government focused on helping disadvantaged families to reduce the number of undernourished children. Health system infrastructure and improving maternal and child care services were done from 2012 up to 2014 to address stunting, and their efforts actually paid off. Correct me if I'm wrong, but in Indonesia, the country Indonesia aims to reduce stunting prevalence to 18.8% by this year, 2026, through targeted nutrition interventions and the MBG-3B program. So this is a national priority nutrition intervention that provides free nutritious meals, delivering high-quality meals to pregnant and breastfeeding women and children under 5 years of age. Global reports state that the prevalence rate is still in the 20s based on the Global Nutrition Report in 2025. Around 150 million are still stunted. And remember that in 2012, the number reported was around 170 to 177 million. So technically only around 20 to 25 million less after 12 years. Globally, malnutrition remains a persistent challenge, and current trajectories indicate that the world is unlikely to meet the 2030 nutrition targets despite pockets of progress. The pace of reduction in stunting is far too slow, hence the urgent need to scale up interventions. Highlighting the long-term effects of stunting. So one, there's a reduced cognitive ability. Stunted children have lower scores in terms of attention, learning tests, and memory. It will lead to lower school performance. So there's a delay in school entry and higher dropouts, causing decreased earning potential as adults. So there's a 22% less over their lifetime. And there's an increase in disease risk. Stunting raises the likelihood of having obesity, diabetes, and other non-communicable diseases. So let's talk about how stunting damages cognitive development. What is the mechanism? So as mentioned, stunting is not only a failure of linear growth, it is a failure of brain development. Evidence shows that stunted children have lower cognitive scores, as mentioned earlier, poorer school performance, and reduced adult productivity. This is because chronic malnutrition affects the brain during its most rapid growth phase, during pregnancy and up to 2 years of age. And scientific studies show that an average loss of around 5 to 10 IQ points were observed among stunted children compared with normal children. And depending on the severity and timing, the loss of IQ points may reach up to 15. The key biological and environmental mechanisms grounded in current literatures are as follows. First, there is the reduced brain volume and impaired neuronal growth. Literature consistently show that chronic undernutrition limits the availability of protein, essential fatty acids, iron, zinc, iodine, and B vitamins, all required for neurogenesis or the formation of new neurons. Synaptogenesis, formation of synapses, and myelinization or insulation of the nerve fibers for fast signal transmission. The Multidisciplinary Digital Publishing Institute review confirms that stunting is associated with poor brain development and cognitive deficits due to this biological disruption. Second is the altered brain structure function. Studies showed that stunted children have smaller volume of hippocampal. So the hippocampal is the small curved seahorse structure located deep within the brain, temporal lobe, and it plays a fundamental role in converting short-term memories into long-term ones and is crucial in terms of learning and installing memories. There's also the reduced prefrontal cortex development that actually governs executive functions like decision making, working memory, impulse control, and emotional regulation. There's also an observed lower white matter integrity, causing slower processing speed when chronic malnutrition occurs. So these structural changes explain why stunted children struggle with attention, memory, and problem solving. Moreover, there is chronic inflammation and gut-brain axis disruption, and stunting is strongly linked to environmental enteric dysfunction or EED. Chronic gut inflammation caused by repeated infections and poor sanitation leads to malabsorption of nutrients, systemic inflammation, and altered gut microbiota. So basically, studies or scientific literature highlights gut dysbiosis as a contributing factor to impaired growth and cognitive deficits. And inflammation interferes with brain development and neurotransmitter production. The fourth developmental effects of stunting is the micronutrient deficiencies that directly affect cognitive development. So key deficiencies include iron deficiencies, which results to impaired myelinization or causing poor attention. Iodine deficiency, it's an irreversible intellectual disability. Zinc deficiency, causing impairment of neurogenesis, and vitamin B12 and folate deficiency results to poor neural tube and brain development. These deficiencies are common in stunted children and directly reduce cognitive performance. So what are the causes of stunting? Stunting is caused by a combination of immediate underlying factors such as lack of stimulation and early child care during the first 1,000 days, and the underlying causes are complex, spanning limited access to health services, poor dietary diversity, chronic food insecurity, poor water, sanitation, and hygiene, and prolonged poverty, plus urban-rural variations, and some gender inequalities. Pregnancy is the foundation of child's growth. Preventing stunting begins even before conception and continues throughout pregnancy because fetal growth restriction is the earliest and most irreversible form of stunting. Pregnancy reflects the mother's entire life course nutrition. A woman who enters pregnancy with conditions like being underweight, anemic, food insecure, or stunted herself is more likely to give birth to growth-restricted infant. Thus, stunting is intergenerational. Breaking the cycle requires intervening before and during pregnancy. The first 270 days of pregnancy is the most sensitive. Damage during this period is fast, rapid, often irreversible, and sets the trajectory for the next 730 days. So again, pregnancy is the single most powerful leverage point for preventing stunting. Stunting is strongly associated with higher risk of type 2 diabetes because early life undernutrition permanently alters metabolic development, insulin function, and body composition. This link is now well documented across epidemiological studies, systematic reviews, and developmental origins of health and disease research. Early life undernutrition impairs pancreatic self-development. So stunting, especially when rooted in fetal or early childhood malnutrition, reduces beta cell mass and function, leading to lifelong deficits in insulin secretion. Systematic review show that individuals with a history of stunting exhibit reduced pancreatic beta cell function and impaired glucose homeostasis, both of which increases the risk to diabetes mellitus type 2. And in terms of insulin resistance increase due to altered body composition. So stunted individuals often develop the thin fat phenotype. So there's a higher abdominal visceral fat, lower muscle mass with normal or low BMI. So this phenotype reduces glucose disposal capacity and increases insulin resistance. These are key drivers of type 2 diabetes. Evidence shows a consistent association between stunting and increased abdominal fat, dyslipidemia, and hypertension, all of which contribute to the development of diabetes. The effects of stunting in relation to risk of type 2 diabetes arise from the intrauterine growth restriction or IUGR. IUGR disrupts the fetal beta cell and electron transport chain, increasing ROS or the reactive oxygen, and this damages the mitochondrial DNA and further impairs insulin secretion, setting the stage for diabetes in later years. Early deprivation of nutrients induces epigenetic modification in genes, regulating beta cell development and insulin signaling, hence increasing susceptibility to type 2 diabetes. And developmental origin of health and disease pathway actually explains in detail its effects. Metabolic programming during the first 1,000 days using the DOHAD format, the developmental origin of health and disease framework explains how early nutrition deprivation creates permanent metabolic programming, including altering insulin sensitivity, the thrifty metabolism, increasing fat storage, and heightened vulnerability to metabolic overload in later life. So systematic reviews confirm that malnutrition during the first 1,000 days lead to long-term metabolic changes that predisposes an individual to type 2 diabetes. The DOHAD framework explains how early nutritional deprivation creates permanent metabolic programming. As mentioned before, we've identified altering of insulin sensitivity, the thrifty metabolism theory, increased fat storage, and heightened vulnerability to metabolic overload later in life. The mismatch between early scarcity and later abundance is a major driver of type 2 diabetes risk. The thin fat phenotype produces a metabolic profile characterized by low skeletal muscle mass, which reduces glucose disposal, high visceral fat, which results to chronic inflammation and insulin resistance, high liver fat, which impairs signaling of insulin, and low fitness capacity, which results to reduced metabolic resilience. Now, this combination is a perfect storm for metabolic disease. And why it increases the risk for type 2 diabetes? Because even without obesity, thin fat individuals show high fasting insulin, high HOMI, IR, and impaired glucose tolerance, and early beta cell exhaustion. Stunting is increasingly understood as a condition with deep roots in mitochondrial dysfunction. The strongest evidence links chronic undernutrition to impaired mitochondrial biogenesis, reduced ATP production, and disrupted cellular growth pathways, all of which contribute to the linear growth failure seen in stunting. Because mitochondria power the brain, the immune system, and the endocrine organs, early life mitochondrial injury has lifelong consequences. Now, this slide illustrates how chronic undernutrition triggers mitochondrial dysfunction, the cell's energy crisis. When mitochondria fail to produce enough ATP, growth plates, intestinal cells, and immune tissues lose their capacity to regenerate and function optimally. The cycle begins with poor nutrition and infection, leading to damaged mitochondria and reduced energy availability. This, in turn, impairs bone growth, weakens gut integrity, and limits nutrient absorption, reinforcing stunting. Over time, the consequences extend beyond height. Children experience weakened immune system, there are cognitive delays, and some metabolic disorders are observed, and of course, reduced physical capacity. Understanding this link reframes stunting not merely as a growth issue, but a systematic metabolic condition rooted in cellular energy failure. It's a key insight for designing nutrition interventions and policy reforms. Now, let me just highlight or emphasize that severe undernutrition disrupts mitochondrial homeostasis. Severe undernutrition reduces NAD availability and impairs the SIRT1 pathway. It is the master metabolic regulator, a cellular energy sensing system where the enzyme SIRT1 uses NAD in regulation of proteins involved in metabolism, inflammation, DNA repair, cell survival, and others. SIRT1 is NAD dependent. NAD, remember, is the nicotinamide adenine dinucleotide. It's a true energy currency in human metabolism and a survival signal for cells. This is very essential for mitochondrial biogenesis and repair. When NAD is low, SIRT1 is also low, and this results to impaired mitochondrial biogenesis and gut barrier repair, resulting to poor intestinal absorption, chronic inflammation, reduced growth plates, and impaired energy metabolism. The implication is that stunted children often have compromised gut integrity or leaky gut, partly driven by mitochondrial dysfunction in intestinal epithelial cells. Rebalancing NAD and SIRT1 restores mitochondrial homeostasis and improves intestinal barrier function and a key organ system affected in stunting. Let's look at this for have a 34-year-old born as a background, but no birth weight.
I think this is the volume of the recording is low. So this is just an example of a case scenario talking about a stunted woman pregnant, and these are actually her conditions. So later on, you can actually have this as an example. So this is a clinical example of pregnant woman suffering who was actually stunted and got pregnant, and these are actually her laboratory tests. I think let's move to the next slide.
Now, after learning what is stunting and its consequences, let's talk about prevention. Good nutrition, of course, is very important. Ensuring provision of varied, balanced, diverse meals during pregnancy and the first 1,000 years of life is very important. Also, access to safe, clean water, which reduces infection that interferes with nutrient absorption and growth. Also, regular hand washing, sanitation, and clean food preparation prevent diseases that can cause nutrient loss and growth delays. Regular checkup is also important. Vaccinations and timely treatment of illness help children grow and develop properly. Caregiving is also important, the quality and care. Play, learning activities that will support healthy brain and physical development from birth is very crucial. Variety, balance, moderation, and diversity. A comprehensive, timely medical and emotional support provided to pregnant women to ensure best health outcome for both mother and child must be given. Remember that we need 40 different nutrients every day, and no single food alone can provide these 40 different nutrients. Basically, we have the same nutrient need throughout the life cycle. It only varies in amount as we age. We need to take action now, create awareness and educate people in terms of stunting. Because remember, as mentioned earlier, the rate of improvement is actually slow. So we have to invest in health, give health a big priority, and participate in monitoring and other health initiatives of the government to be able to address the problem of stunting. And so what are the important insights that I hope I was able to impart to you today? One is that stunting represents chronic undernutrition and is largely irreversible, impacting cognitive development and overall productivity. And there's a need for a combination of interventions to improve the rate of prevalence, which is actually not met in terms of global target of addressing the problem of stunting, and significance of good nutrition throughout the life cycle, and that stunting increases the risk of diabetes and other metabolic diseases in later life because of chronic undernutrition. Let me share the major resources that I've used in this presentation. As disclosure, images and some content in this presentation were generated using Microsoft Copilot. Again, my name is Amy Sherry Barion. I'm from the Institute of Human Nutrition and Food, College of Human Ecology, University of the Philippines, Los Baños, and you may contact me through my email, aabarion1@up.edu.ph. Thank you, and I hope you were able to grasp the importance of good nutrition throughout the life cycle and what is stunting all about.
Wow, the material is very good. Alright, now we'll move on to question and answer session. If you wanna ask, you can raise hand or write it down in our chat room by telling your name with the question.
I think Miss Sinta is raising her hand.
Okay, so I got the first question. For the first question is from Cinta Shakila. Please to Cinta Shakila tell the question.
Okay, thank you for the chance to asking about the topic, the last topic. And good morning, doctor. And I'm Cinta Shakila from Applied Undergraduate Program in Midwifery. And I would like to asking about the topic that you mentioned at the first. It's about the recent evidence suggests that intrauterine hypoglycemia might trigger fetal programming process through epigenetic modification. So, in your opinion, to what extent can these epigenetic changes be recovered if the mother's blood glucose level have been optimally controlled from the beginning of the first trimester? So that's my question.
Actually, the presentation is about a normal pregnancy and about stunting. Assuming that the pregnant mother, is not diabetic normally, but has inadequate nutrition during pregnancy, the result will be baby having stunted children and lower cognitive and later on developmental problems. So the scenario is more of a normal case. Now, if the mother is also suffering from diabetes, that will also result to further problem of having not only stunted children, but having also maybe later on chances of having the child or the infant having suffering also from diabetes or other metabolic problem. But this one, the focus here is a normal mother having inadequate nutrition resulting to poor nutritional status of the child and chronic undernutrition. And later on, when the child grows up, the chances or risk of having non-communicable diseases is actually very high. So that's the problem. Globally, in my experience here in the Philippines, we are really having a very high prevalence. So we are looking at productivity because there are many stunted Filipino, and the government is thinking later on in the future, Filipinos will not be that productive because of lower cognitive development and then the high risk of having diabetes. So health services must be provided, and that is actually quite expensive. So that's actually the call right now to make not, if not really stop, but lessen the number of having or having the chance of having more stunted children for future development. Thank you, Sinta. Good morning.
Thank you for the explanation.
Miss Siti Noor. Good morning.
Okay, so I got the next question. For Siti Nurfairuz Aziza Ghazali, please tell the question.
Okay, good morning, Doctor.
Good morning.
Okay, thank you for respected moderator and honorable speaker. And my name is Siti Nurfairuz Aziza Ghazali, and I'm a second year midwifery student at Poltekkes Kemenkes Tasikmalaya. Okay, my question is, you mentioned in your presentation is several strategies to prevent stunting, including proper nutrition, clear water, hygiene, and healthcare access. If parents are unable to implement all these at the same time to limited research, which intervention should be prioritized first and why?
Very nice question. Actually, it's really very hard. No, there's no single solution to really stop stunting. So it's really a combination, just like what happened in Nepal and Peru. And actually, that's also the strategy or approach of WHO, UNICEF. It's a combination of efforts, educating the mothers, providing health. It's simultaneously combined efforts of agriculture, education, local government units. To answer your question, and also based on my experience, there's no single solution. No, it's really a combination. But maybe to knowing that we have less resources, the priority I think really is to provide maternal and childcare services. That's the first. I think if we have really limited resources and I'm asked to what to do is really to provide extensive resources in terms of maternal and child services. And it will cover actually education, training, facilitating, providing not only services, but maybe meals as well, all under the umbrella program of maternal and child care services. But in reality, it's a combination. Because in our experience here, sometimes the family depends on the services. when the services are not available anymore, it will not be continued at home. So in terms of sustainability of the program, that's the problem. So education, actually, it's very important, no, part of advocacy. Good education, learning, understanding why health, nutrition is very important. So that will have the sustainability, no. Also, local government units must sustain, because politics sometimes also plays an important role. Sometimes the politicians have their own priority, military, education, or other, not health. So if the mayor, governor, or the politician changed after 3 years of term, or after 5 years, the program is actually stuck. So it should be continuous. So those are actually the problem. That's why it's really a combination when we talk about sustainability. Thank you.
Okay, thank you, Doctor, for your time and your explanation.
Thank you.
Alright, question and answer session is finally finished. Thank you so much for your amazing answer and explanation, Miss Amy. All of the questions has been answered. Okay, before we end the session, allow me to read the conclusion about our discussion today. Stunting isn't only a childhood problem, but also a lifelong challenge that begins during pregnancy. Adequate maternal nutrition, quality antenatal care, and proper nutrition throughout the first 1,000 days of life are critical to preventing fetal growth restriction, breaking the intergenerational cycle of stunting, and reducing the future risk of type 2 diabetes and other metabolic diseases. Addressing stunting requires coordinated efforts from families, healthcare providers, communities, and government to ensure every child has the opportunity to achieve optimal growth, health, and lifelong potential. Investing in maternal and child nutrition today is an investment in a healthier and more productive future generation. Finally, now we have reached the end of this webinar session. I would like to say thank you to Dr. Anishiri of Barbarian and PhD as our speaker for the great webinar, and also to the audiences for the active participation. We got a lot of great knowledge from here. Okay, Miss, we also have an appreciate certificate for you as a speaker. To the IT team, could you help me for sharing the certificate, please? Okay, Miss, this is the certificate from us. May this certificate be beneficial for you. Okay, before we end the session, could we take some pictures together, Miss?
Thank you.
Okay, everyone, please open your camera and give your pretty smile. To the documentary team, could you help me for screenshot the picture? Okay, we can start screenshot this slide. 1, 2, 3. Perfect. Alright, now let's take some pictures together. Let me say something to you, Miss Amy. You're very good for today's webinar, and it's such great fun for us to having insightful discussion with you. Thank you very much, Miss. May you always healthy and happy every day.
Thank you.
Last but not least, I would like to extend my appreciation to all of us for learning together in this session. May you always happy and after joining this webinar. Please give applause. Finally, I'm Nabila Putri Nuranianti as the second moderator as for leave. Now, I'm handed over again to the next moderator, Devira Mellitus. The stage is yours. Nabila Putri Nur Armianti for letting me to lead this session. Assalamualaikum warahmatullahi wabarakatuh. Good morning to our distinguished speakers, honorable guests, respected lecturers, and dear all participants. Welcome to this Zoom meeting of International Webinar on Midwifery Student Association 2026, Tasikmalaya Health Polytechnic Ministry of Health, presented by them. Golden Indonesia begins with smart parenting, managing stunting in children to prevent double the risk of diabetes mellitus in realizing a healthy and intelligent generation. I'm Devira Mawati Iksan. It's my honor to have opportunity to be a moderator for this webinar. First of all, let us say thanks and pray to Allah Subhanahu wa Ta'ala for giving us the grace of health and safety so that we can gather in this webinar. Okay, everyone, it is my pleasure to introduce our esteemed speaker, Dr. Norbaizura bin Muhammad Yusuf, PhD, Senior Lecturer and Clinical Dietitian at the Department of Dietetics, Faculty of Medicine and Health Science, University Putra Malaysia, Malaysia. Before we start discussing, let me read the CV of our third speakers. To the IT, could you help me for sharing the CV, please? Okay, her name is Mrs. Norbaizura bin Muhammad Yusuf. She was born on September 16, 1981 and currently resides in Sari Kembangan, Selangor, Malaysia. She is a senior lecturer at the Department of Dietetics, Faculty of Medicine and Health Science, University Putra Malaysia, and serves as a dietitian at the Hospital Tamajar University Putra Malaysia. She completed her Bachelor of Health Science honors in Dietetics at University of Malaysia 2003, earned her Master of Science in Community Nutrition at University Putra Malaysia 2008, and obtained her PhD in Community Nutrition from University Putra Malaysia 2017. Her professional career includes her role as a dietitian at University Malaya, followed by her tenure as a tutor and subsequently a lecturer at University Putra Malaysia. She has also gained extensive clinical and research experience through specialist training in pediatric nutrition at the Institute of Pediatric Hospital Kuala Lumpur and as a researcher at York Children's Hospital, University of Glasgow. In addition to her academic and clinical responsibilities, Dr. Noor is actively involved in extensive research activities and has received numerous awards for her academic excellence and teaching innovations. She has consistently contributed to the field through various publications and research projects as detailed in her CV. Wow, our speaker is truly outstanding, right? Okay, I have down for you the CV of our speaker, Mrs. Norbaizura, and I think Mrs. Nor have already joined us right now. Dear all participants, please join me in giving a warm welcome to Dr. Norbaizura bin Muhammad Yusuf. Excuse me, Mrs., are you there?
Yes, I'm here. Can you hear me?
Okay, how are you, Mrs.?
So far, I'm fine. Good.
It's glad to hear that. Thank you so much, Mrs., for joining us today. Okay, before we start discussing, let me tell the audience how the presentation will go. For the third speaker, Dr. Noor will present the material for 13 minutes, and after that, there will be a question and answer session for 10 minutes and followed by a conclusion. Okay, Mrs., have you ready for giving the material?
Should I share or how is it?
Okay. Now let's straight away listen to the material that will be presented about identifying stunting as a predictor of insulin resistance and early onset diabetes mellitus in children. Please welcome Dr. Norbaizura bin Muhammad Yusuf. The stage is yours.
Okay, Bismillahirrahmanirrahim. Assalamualaikum and good morning. I believe it's still morning, right? Okay, we in Malaysia already 11, towards lunchtime. Okay, so my name is Dr. Nabaizura Mama Yusof. I'm from a senior lecturer from Department of Dietetics, Faculty of Medicine and Health Sciences, University Putra Malaysia, and also practicing as a dietitian at our teaching hospital, what we call Hospital Sultan Abdul Aziz Shah. All right. So before I start, I would like to thank to the committee for inviting me for this webinar. And of course, my topic that given to me is identifying stunting as a predictor of insulin resistant and early onset diabetes mellitus in children. So for me, I'm happy for this topic as now I have my own clinic that focusing on the child obesity and also type 2 diabetes mellitus. Okay, so can we move to the next slide? How is it? Should I share or is it? Okay, please to the next slide. Myself to share the slide. Um, no, should I share the slide?
Yes, sure.
Okay, sure. Can you see the slide?
Yes.
Good. Thank you. So, before we start, I just like to have an idea from this illustration. Yeah. Okay. So from here, we can see that intrauterine growth restriction and also prolonged malnutrition can lead to early life stunting. Yeah. And this one, it will lead to the beta cell damage and also mass reduction in terms of muscle mass. And then this situation will lead to insulin resistance, which cause the peripheral glucose uptake failure and also hepatic valve failure. And these two conditions will lead to type 2 diabetes mellitus. So why I share this illustration? Because my talk later on will more focus on this as well. Okay, previously I talked about the intrauterine growth restriction, right? So we look at this illustration, right? So we have intrauterine growth restriction. It can be happen less than the 22 weeks of gestational age. So we know that, for example, we have preterm baby that birth after 37 weeks, and full-term baby we know actually is 40 weeks. So baby birth at birth, let's say 37 weeks of gestational age, they may have some of the organ may be still immature. So because of this, what we call just now intrauterine growth restriction, this group of baby also can cause stunting in the future, and some of the organ may be immature as well. And this is part of, then we also have a baby at birth 40 weeks, but somehow because of the prolonged malnutrition, they also can lead to stunting, right? And they also have issue on the diabetes mellitus. They have a risk of diabetes mellitus as well. So to begin, just to think about the postnatal, I mean the baby that this part, right? Yeah, this group of baby. So this group of baby actually at birth, many physiological and metabolic system are still immature, right? So this system continue to develop during the early postnatal period. So it's still continually growth, early postnatal period, making infancy actually another critical window for metabolic programming. So they need to have a good nutrition for that, right? So poor nutrition after birth may produce metabolic adaptations similar to those caused by prenatal malnutrition. So we may have heard any references or any study that say that prenatal malnutrition also the fetal need to adapt with the situation, right? The same goes to the postnatal baby. Okay, so what you call the critical window for metabolic programming. So there are many research studies shows that evidence linking between postnatal and undernutrition to adult disease. For example, low weight gain during infancy, right, is associated with an increased risk of coronary heart disease and also type 2 diabetes mellitus, right? It's not it is independently from birth weight, meaning that the baby may have a different range of birth weight, right? But weight gain during the infancy also is so important that determine the risk toward CVD and also diabetes. Yeah, it's not just talking about the preterm baby, it's not talking about the normal baby, but those with prolonged malnutrition. But if let's say we don't provide a good nutrition support to cause a weight gain, somehow they may have a risk towards CVD and also diabetes. Okay. So just to recall, maybe some of you already went through, right? So this one is about what are the system that immature and what are the problem related to, right? Because this talk about the premature baby, for example, right? So premature baby with a full-term baby, but maybe with the prolonged malnutrition, for example, they can lead to many undernutrition issues, right? So one of them is stunting. So for today, we try to focus on the stunting issue that link to diabetes mellitus. Right. So it's just introduction from me. Yeah, to recap some of the knowledge that we may have about this. So for today in thought, actually, I will look at the introduction, the stunting and the emerging burden of early onset of diabetes. What is the current situation for the stunting? And of course, the burden of the diabetes mellitus by itself. Stunting as predictor of type 2 diabetes mellitus, how is linked together, right? And then we look at them, we dive further for the third topic to look at the pancreatic adaptation and metabolic programming related to the pancreas. So pathophysiology of insulin resistance in stunted children, yeah, we try to, instead of look at the pancreas, we look at also the body composition. We look at the muscle mass, how it's linked to the diabetes mellitus. And of course, after we look at this, how the stunting linked to the diabetes mellitus, we need also consider for the rapid catch-up growth, right? I believe if we say some of you went through about the preterm baby, for example, or small baby, for example, catch-up growth is so important. But now we talk about rapid catch-up growth, and what are the metabolic consequences. And of course, after that, we need to know what are the important, what are the components inside the early screening for diabetic risk. And then, of course, I try to end up with the integrated nutritional intervention for prevention and also the take-home message. Right. Now, we're talking about stunting, right? Stunting actually still remains as a major global public health challenge, right? And stunting actually is a chronic undernutrition during the most critical periods of growth and development. In year 2024, it was estimated that about 150.2 million children under 5 years, is about 23.2% actually were stunted. And this, most of them is come from come from Asia and Africa. But we have to note that stunting is not just far away from the linear growth, impact linear growth, but is also associated with poorer cognitive development, reduced educational attainment, lower economic productivity in the future, and increased susceptibility to chronic disease later in life. Right? So this is what are the things that are what are the consequences of the stunting. When you look at these geographical maps, right? It shows that African and Asia sub-regions have the highest stunting prevalence. We still face the problem, right? So that's why we need to have this kind of webinar, isn't it? Okay, so we know that burden of type 2 diabetes in adults is increasing worldwide, right? And now we not just talk about the diabetes in adults, right? But now we talk about is increasingly diagnosed in children, adolescents, and young adults. In my clinics, I have many patients that already, type 2 diabetes as early as 13, 14 years old, adolescent age, right? Early onset type 2 diabetes progress more aggressively than adults onset disease and is associated with earlier macrovascular and cardiovascular complication. It means that, for example, if children diagnosed with diabetes, they will have the complication earlier than adults. Okay, that's why we need to prevent them from the diabetes. The rising trend is driven not only because of obesity, because of the good nutrition in some situation, right? For example, in my clinic, maybe most of them because of the really good nutrition, is because of the obesity, but also by early life nutritional and developmental factors. Early maybe they are low birth weight baby, they are stunted children, but somehow with the catch-up growth, and then they become obese and they have a risk towards the diabetes. Okay, so double burden of malnutrition. We have many countries, we have double burden, we have triple burden, right? So double burden because we have one side is undernutrition and another side is obesity or diabetes. Okay, so I'll try to another things important here to share with all of you. Children who experience early undernutrition. Okay, at early phase is undernutrition and somehow followed by rapid nutritional transition are particularly available to future metabolic disease. If let's say rapid nutritional transition. We're talking about the rapid nutritional transition. It's not just, we provide the good nutrition intervention, but we know that the current situation, we have many processed food, we have many food that high in energy dense, right? So this also can lead to the diabetes mellitus for this group of patient. Sorry. Okay. Then why we need to focus? We talk about the diabetes, we talk about high risk of many complication, right? Because this could actually early life marker of metabolic vulnerability, rather than just indicator of poor growth, right? Because previously we have mindset that, oh, it's just poor growth, it's just a small. And if we're talking about the size, we now look at it in detail. But then according to Dohart is one of the big study, right? Developmental origin of health and disease. Dohart hypothesized that nutritional deprivation during fetal life and early childhood induce permanent changes in organ development and metabolism. It's not good, right? Where it predisposing individual to insulin resistance and type 2 diabetes in later life. So, we know that study result from the prolonged nutritional deprivation during the fetal life, and therefore we have noted that 1,000 days, right? I think many of us heard about the 1,000 days, right? Is a critical window for organ development and metabolic programming. Okay, so less than 2 years is so important. This early life adaptation may have lifelong consequences on glucose metabolism and insulin function. So this group at this what you call a critical window for organ development is need to have a right intervention. Developmental programming links stunting with future diabetes, right? Again, for the DOHAT study, right? Poor nutrition during fetal and early postnatal life, as I mentioned before, right? Based on the illustration. So, induces adaptive metabolic changes that improve short-term survival. All right. So, baby at birth with small one, they already adapt to that situation. But somehow, if let's say very good nutrition, we provide very high energy, somehow it will cause another issues. However, however, these adaptations become maladaptive when individuals are later exposed. Yeah, they already adapt with their situation with the less nutrient, for example, exposed to energy rich environments, increasing the risk of obesity, insulin resistant, and type 2 diabetes mellitus. So we look at this graphic, for example, we know that chronic undernutrition, stunting, right? It's not just the size of the body. We have to look at in detail what happened to the organ as well, right? So, sorry. So for these growth stunted children, right? They have metabolic programming and organ damage because the body prioritizes survival. Okay, during that inadequate nutrient, inadequate environment, they prioritize to survive. Okay, therefore they compromise with the development of the pancreas, liver, and certain important organ. Right. So therefore, it is condition in later life it will cause to the diabetes, right? Insulin resistant and type 2 diabetes, all right, because of the, because of the structural vulnerabilities lead to chronic metabolic failure and early onset type 2 diabetes. So this one is getting worsening, right? When the child is exposed to another environment, the global double burden, whereby we have, high exposure to processed food and food high in energy density. Sorry. All right. So, stunted children exhibit metabolic alteration before diabetes develop, right? Because they may have issue on the impact pancreatic beta cell function. Therefore, it's alter the insulin secretion, reduce glucose tolerance, they cannot tolerate with the glucose, and the lowest skeletal muscle mass, which we'll look at in detail later. Increased insulin resistance, particularly following the rapid catch-up growth. Right, it continuously because of the catch-up growth. Somehow later on we discuss on this. It will lead to the insulin resistance. So this is also proved by the epidemiological evidence that supports stunting as a risk marker or risk factor for the diabetes mellitus, whereby they look at those who have a low birth weight, okay, intrauterine growth restriction, childhood stunting, actually are associated with increased risk of insulin resistance, impact glucose metabolism, metabolic syndrome, and type 2 diabetes in adults and adulthood, right? It's already proven in the epidemiological studies. Okay, we talk about the beta cell, we talk about the organ, we talk about the potential of body composition for the muscle mass later on as well. But I just plugged this one. This is my from my preliminary study, right? This shows that actually baby with low size or baby with low birth weight actually linked with the face angle. This is group of baby study actually less than 12 years old. So I'm trying to say that the face angle actually is the useful biomarkers of cellular health. We're talking about cellular health at the cell level. So at the cell level, those in low birth weight already have the issues on the not good nutrition or inflammatory status. Right? So this one another quite latest method how to determine, how to link the potential between low birth weight with the risk of certain diseases because of the cellular health is not in good situation, they have less nutrient and it could be linked to the inflammatory status as well. So I hope that in the future, we can prove that actually cellular health, which is measured by the face angle, is linked to the diabetes as well. So, the clinical implications, right? We have to look at back after my several slide just now. Stunting should not be viewed slowly as impact linear growth, right? We just look at the stunting, all right? And then we just imagine the growth chart, right? But supposedly, yeah, it's an early life indicator of metabolic vulnerability that identify children at increased risk of developing insulin resistance and early onset of type 2 diabetes, right? We look at this graphic, right? So we just look at this baby, this child. Look at a child, stunted child, very small, right? Okay, but somehow it's just the tip of the iceberg. Okay, but if we look at the detail, there are many other issues that we have to look at. All right, we have issue on the brain and cognitive development. We have immune system impairment, and of course we have metabolic organ damage as well. So for today, for the next slide, we focus on the how the body actually prioritize survival over development in times of nutrient scarcity, lack of nutrient. The body prioritize basic survival over the healthy development of organ like the pancreas and the liver. Okay, they need the energy for survive. Right? That's why they compromise the development of important organ like what we call pancreas, liver. Right? So when we look at these issues, right, we noted that based on our knowledge, right, the pancreas beta cell are critical for glucose hemostasis, right? Beta cell is the isolate of Langerhans that produce and secrete insulin in response to the elevated blood glucose. Okay, we noted that. Insulin promote glucose uptake by skeletal muscle and adipose tissue while suppressing hepatic glucose production. Okay, and the normal beta cell development begins during fetal life and continues throughout early infancy. So we know that it's so important, but like before, right, it could be the development is not so good because the body already compromised. Yeah, they focus on the survival instead of the development of the kind of organ. So again, yeah, critical windows for development that we need to focus, 1,000 days from the conception to 2 years is a crucial period for the pancreatic growth and beta cell maturation. Okay, so therefore this is so important to make sure all of this. Okay, so optimal nutrition during early life is essential for establishing adequate beta cell mass and insulin producing capacity. Yeah, we need to note that. But later we look at that, how the optimal nutrition is. Okay, just to summarize back, the one that we talk about the pancreas, we noted that rising blood sugar level in our body, for example, increased glucose in the bloodstream triggers a response within the pancreas. And therefore, the isolate of Langerhans response, specialized beta cell detect the high glucose and prepare to release the insulin. And therefore, facilitating the glucose absorption whereby secreted insulin allows the body cell to take up glucose for energy. Right? So this is pathway that we have in our body. But somehow for the stunted children, they may have this issue. Yeah? Because issue with the pancreas damage, for example, right? So they have like malnutrition caused by the body to compromise the development of pancreas. We talked just now. And therefore, it's linked to the compromised organ lead to early onset diabetes and heart disease in adulthood as well. Okay, just now we talk about the pancreas, and then we talk about how the insulin and the muscle, why is so important muscle in here, right? Secreted insulin allow the body cell to take up glucose of energy. So it mainly is the muscle mass. So in our body, skeletal muscle is primary site of glucose disposal, right? So skeletal muscle accounts for 70% to 80% of insulin stimulated glucose uptake after a meal. Insulin promotes glucose transport into muscle mass through our GLUT4 translocation. Okay, so healthy muscle mass is therefore essential for maintaining normal glucose homeostasis. But for children with stunting typical, right, they have, of course, they have reduced lean body mass, right? They don't have enough lean body mass, lower skeletal muscle mass, and reduced glucose storage by glycogen. Therefore, decrease insulin and then stimulated glucose uptake. And what are the consequences? So, reduced muscle mass lead to elevated circulating blood glucose, right? Increased insulin demand, okay? And then compensatory hyperinsulinemia, and therefore, in long term, it will progressive insulin resistant and it will lead to the type 2 diabetes, right? So that's why when we look at the iceberg just now, it's not just talking about the size, the small body, but we talk about there are many other things. For example, with immature or in underdevelopment of pancreas is not function very well. And then also we noted that stunted children, they may have very less body composition in terms of muscle mass, right? Okay, so therefore, okay, we concluded that in stunted children, reduced skeletal muscle mass limit insulin, mediated glucose uptake, while increased visceral fat, alter body composition, promote chronic metabolic dysfunction. Right? Together, these changes drive insulin resistance and substantially increase the risk of early onset of type 2 diabetes. Okay, so it's more towards on the in started children, it's more on the the muscle mass is very less, okay, but then the fat accumulation is there. So now we know they need a good intervention, right? And therefore we need to catch up growth, right? So being a dietitian, yeah, is my role as well to provide a good nutrition for this kind of baby. So therefore, we need to have provide a good nutrition, what you call catch-up growth. But rapid catch-up growth is another thing, is another story that we have to careful because it linked to metabolic consequences. Okay. So what happened when we rapid catch-up growth? It's not the one that we really monitor, it's very rapid catch-up growth. For example, what will happen to them is more on the prefunctional fat deposition, right? It's more because, for example, we provide high energy, okay, high in energy, food that high energy density, we focus the energy, so it's more on the fat deposition. It's not muscle mass because we talk about the total intake, yeah, the total energy, not really the balance of the nutrient inside the meal or inside the food. Visceral adiposity, hyperinsulinemia, reduced insulin sensitivity, chronic low-grade inflammation and lipotoxicity, and hepatic insulin resistance because of the fat accumulation. Okay, so early undernutrition program the body to conserve energy during rapid catch-up growth. Fat mass is restored more rapidly than lean mass. So we want to make sure the baby is getting better, it's getting big, better and big in size little bit, right? But somehow we just push them, right? So give without concern about the well-balanced diet, right? It just focus on energy consumption. It's focused on the fat mass is restored more rapidly than lean mass. Skeletal muscle glucose utilization decrease, and excess glucose is professionally stored as fat. Okay, excess the glucose, and this increase the risk of obesity, insulin resistance, and metabolic syndrome. So, what are the clinical implications, right? So we need to regular growth monitoring. We not just give the intervention. Balanced nutritional rehabilitation. We not just focus on the calories. We focus on the balanced nutrition. promotion of lean mass acceleration through adequate protein intake and physical activity. Yeah, so we need to focus on the food protein intake, not just give them or provide them very high in energy. Monitoring the metabolic risk factor, I cannot see, sorry, risk factor during ketchup growth. So, what we can summarize here, the quality of ketchup growth is as important as the quantity. Recovery should prioritize balanced linear growth. Right? We need to monitor the growth and lean mass rather than excessive fat accumulation, not just the fat accumulation. Okay, because just now we talk about the rapid ketchup growth, but what is rapid? What is ketchup growth actually? So the ketchup growth within the first 2 or 3 years is so crucial after delivery. It's so crucial. We're provided with adequate nutrition. Okay. And of course, the rate ketchup growth is very according to the many factors because we not just give the food like that. We need to consider many factors. Yeah, the weight at birth, for example, gestational age, at what age baby, is it full-term baby? Is it a low birth weight baby, small baby, right? Parental size, adequacy of intrauterine growth factor, neurological impairment, is there anything about that? Clinical causes and nutrition. Okay, so it's not just simply the ketchup growth, it should be a proper ketchup growth. It's not rapid ketchup growth, right? We have considered many factors. So, we noted about the pancreas just now. We noted about the muscle, right? The body composition, how the rapid ketchup growth will link to the increased fat mass instead of lean body mass, right? So therefore, we need to know how we can detect diabetes. Okay, so of course, we talk about the beta cell just now, right? They may have, children with a history of stunting may have reduced beta cell, reduced skeletal muscle mass, increased visceral adiposity following ketchup growth, right? Because of the rapid ketchup growth, greater susceptibility to insulin resistance and early onset of type 2 diabetes. Therefore, for the screening, the children should be screened for the history of stunting or low birth weight or SGA baby, small gestational age baby. Rapid ketchup growth, is there any proof for that? Overweight and obesity, family history of type 2 diabetes, right? And the sign of insulin resistance. Because we can look at the physically, they will have at their neck, for example, at the back, they will have acanthosis nigricans. So, okay, so growth and stress assessment, right? For the assessment part, we need to know the height and for age. For example, use the WHO growth chart standard. I believe some of country rely on the WHO, but certain country they have their own growth chart, right? Weight and BMI trajectory. It's so important. We just not look at the normal or the how much the weight increase, right? Based on the recommendation, based on the duration. We need to study the trajectory. Why all of a sudden the weight is increased? You know, they have like very small child, and all of a sudden increase in big amount of weight. What are the factors that cause the BMI trajectory? Growth velocity, how much to increase? We need to particular on this, not just say that, oh, you have to increase your weight. It's not like that. Okay, history of ketchup growth. Well, and then we have to know how the case, how the baby or the child receive the food and the history, how is it? Yeah, because this is so important. Okay, I have a patient, after we follow up to approve the weight, but somehow the mom not come to see us after 1 year. You know what will happen to the child? It's obese. Yeah, because we need to monitor closely because the changes in terms of the weight changes, in terms of the calorie prescription as well. Okay, And then not just look at the growth chart, we need to look at the metabolic assessment. High-risk children. Who are the high-risk children? Maybe the fasting blood glucose level, HbA1c, yeah, the level of the level of HbA1c, oral glucose test. If let's say something not right, we may proceed to the OGTT test. Okay, to make sure that they high risk of diabetes or not. Fasting insulin, home IRR, this is very expensive. So it depends on the center. Some center provide it freely. For example, my clinic, because of the research purpose, right? So we have the specialist setting, for example, then we have for that. In certain health clinic, maybe not, because it's very expensive. So we may rely on the fasting blood glucose. All right. Lipid profile and blood pressure. Right. So we have to monitor this one. And then we need to okay, sorry. So we need to monitor the biochemical profile, the anthropometry of the patients, right? To check, to alert on that so that we can monitor them, right? So for the integrated nutritional intervention for prevention, I just give briefly, right? But in the later in the discussion, if it's you have any kind of question about the diet, for example, I'm willing to answer that question as well. So life course approach to prevention, preconception and pregnancy is not just the stunted children. Yeah, we have to look at the mother, right? Improve maternal nutrient status before conception, right? We need to know how much they need to have the weight. How about the nutrient status before the pregnancy? Ensure adequate energy, protein, iron, folate, iodine, and other micronutrients during pregnancy. We have to monitor them. What are the weight they have supposed to increase? How much, right? Prevent intrauterine growth restriction and low birth weight baby. Sorry. Okay. And then for the first 1,000 days, right? Promote exclusive breastfeeding for the first 6 months. Okay, next month is the World Breastfeeding Week. Yeah, so we need to celebrate the breastfeeding week. Introduce timely, safe, and nutrient-dense complementary food at 6 months. Okay, ensure the good quality and good portion for the food for the baby. Ensure adequate protein quality and micronutrient intake, not just give the high in calorie. Yeah. We need to consider the amount or the balance of the macro and micronutrient inside the meals as well. Prevent infections through immunization, hygiene, and sanitation. Of course, we talk about the food security, for example. This is also a part of the food security. Okay, and then life course approach to prevention, childhood and adolescent. We have to monitor growth regularly using the WHO growth chart standard. It could be based on the country as well. Encourage balanced diet, not just high in calorie, and age-appropriate physical activity. We need to encourage them to do some kind of activity, movement according to their age. Avoid excessive energy intake, of course, because it leads to the fat accumulation instead of muscle mass, right? Okay, that promote the rapid fat gain. Prevent overweight, prevent overweight obesity by supporting healthy linear growth. Okay, this just to share with you. Some of you already know about this. So usually when we monitor the child, there are many recommendation that we can rely on. Yeah. So how much to gain the weight? It's not just simply, oh, you have to increase the intake, just leave it. But we have to close monitor their weight changes. The weight velocity to make sure they achieve the target, but not beyond than that, because it can cause obesity as well or diabetes in later life. Okay, so this is just an example. All right, we need to monitor them. Yeah, they may not cross from here to up there, right? Straight away. It's good to monitor them, even though it's still here, right? Slowly we monitor, not rapid catch-up growth. Slowly monitor them, provide a good nutrition in terms of total energy and also the well-balanced diet with good enough protein. So hopefully they can slowly cross the line to normal. Right, so we provide is a good enough calorie, yeah, to increase the weight until slowly cross the line to the green color, not very high trajectory just crossed the line. Yeah. This is an example. And before I end up my talk, I hope that we can recap back, right? So stunting is more than impact linear growth. It's not just about growth. It's not just about the size, the small of the child, right? But it's an early life marker of metabolic vulnerability that increases the risk of insulin resistance and early onset type 2 diabetes mellitus, right? And then, sorry. Okay. So, beside that, early life undernutrition permanently alters pancreatic beta cell development, insulin secretion, and glucose metabolism throughout metabolic programming. Yeah. So some of them already have, because I mentioned just now, they have issue in terms of pancreatic, right? Because of the early life undernutrition. So this is some sort like metabolic programming. It's already there, right? And then, reduced skeletal muscle mass and altered body composition in stunted children impair insulin sensitivity, predisposing them to metabolic
You have 2 minutes remaining.
Okay. Rapid catch-up growth, particularly when categorized by excessive fat accumulation rather than lean mass gain, accelerate insulin resistance and diabetes risk. Okay, so we have to be careful when we conduct a catch-up growth. And lastly, early growth monitoring, is so important. Targeted metabolic screening and integrated nutritional interventions, especially during the first 1,000 days, are essential to prevent both stunting and also future type 2 diabetes mellitus. With that, I end my presentation. Thank you. Okay.
Wow, what an insightful explanation. I truly appreciate your dedication to delivering the materials of brilliant analysis. We got a lot of knowledge from here. Alright, now we will move to the question and answer session. If you want to ask, you can raise hand by telling your name and the question. Is there a question? But excuse me, Mrs. Will the question be answered immediately or will they all be collected first?
I think we need to respect the time, right? So, I can answer the question whatever we have first.
Okay.
Well, the Q&A, is it at the chat box? Is it in the chat box? Okay. So how is it? Should I so how can I get the question?
We have one questionnaire from Aulia, and I welcome Aulia to ask the question.
Okay.
All right, thank you so much for the amazing materials and amazing presentation. It's very easy to follow, but I got curious about one thing and just come up with a question. And is not likely to develop these metabolic disorders later in life. So maybe that's my questions. Thank you so much.
Sorry, is it Aulia? Sorry, I just hear your question halfway. It's not really clear. Can you repeat again?
All right, yes. So my question is, not all children who experience stunting develop insulin resistance or diabetes mellitus. So what factors determine whether a stunted child is more likely to develop these metabolic disorders later in life?
Okay. I hope I give you answer. Okay. Of course, there are many children, right? There are many group of children. We have stunted children, we have those with normal one, and with those with actually high risk as well, right? So usually, in my clip, for example, when we say that we talk about diabetes among children, right? Usually they are very big in size. Yeah, right. And some of them actually have normal weight. They don't have any problem about stunting. Yeah, because this is more on the normal baby, normal weight, right? But they have a very good nutrition. Yeah, they have some sort of behavior issue as well. They want to eat more and more. Okay, and some of them may have issue in terms of genetic as well, because some of the genetic issues also related to the diabetes as well. Right. And then some of them actually maybe predisposed to the environment that can cause obesity, the family environment, the school environment, something like that. Right. This is what talk about the children without the stunting issue. The children with the stunting issue actually, there are many, if let's say we treated very well, when we diagnose them actually as a stunted children, we need to have a proper management. Yeah, being a dietitian or nutritionist, for example, we need to know how much we need to provide calorie for them, and we need to close monitor them. Okay, so it's stunted children with close monitoring, with good nutrition, with good management, we hope that they slowly increase the weight and better, isn't it? But somehow, sometimes, we're not really close monitor, or they just, we see the patient is, or the child is very small and they want to increase the weight. So we just provide the food without noted any important in terms of the nutrient. We just give, right? Maybe sometimes, you just give the rice. Rice is carbo. So it's, let's say, beyond the requirement for the carbohydrate. So the extra actually can convert to fat in our body, right? So therefore, they may increase in size. But if we look at in terms of body composition, the muscle mass is less, yeah, but the fat is increasing. Okay, so therefore, for my own clinic, when we look at this child, all right, when we intervene the children, we also conduct the body composition to see the fat is increasing or the muscle is increasing, instead rely on the BMI and also the weight. Is it answer the question?
Yes, absolutely. Thank you so much.
Okay, thank you. Do we have any question?
Okay, Mrs. We have a second questionnaire is from Ramiza, and I welcome Ramiza to ask the question.
Okay.
Thank you for the opportunity. Allow me to introduce myself. My name is Rami Zaila Himansha, and I am a student from Diploma of Midwifery study program at Poltekkes Kemenkes Tasikmalaya. I would like to ask a question. Do you think current child nutrition programs should also include long-term metabolic monitoring, considering the possible link between stunting and early onset diabetes? Thank you so much.
Okay. So thank you, Rimaiza. It's really, for me, it's really important question. And somehow it noted that you are really alert about the program. Yeah, I believe we noted that in many countries, we have many program in the community as well, and also in the hospital or clinic, health clinic, right? So happy to hear this kind of question because in Malaysia, I believe in Indonesia also we have many programs. For example, we have school feeding program, right? Yeah, we have school feeding program is one of the important program to convert or to tackle the childhood problem in terms of stunting or the obesity, yeah, undernutrition and overnutrition as well. So there are many program in the community and also in the clinic, health clinic, and also in the hospital. Actually, depends on the setting. Yeah. So now I think the question is that the current program, how actually we monitor it, not just certain measurements, but how we monitor towards the risk of certain condition that lead to diabetes or any other diseases like cardiovascular disease, for example. Yep. I'm happy to hear this kind of question. Okay, so I'm not sure the current in Indonesia or in Malaysia, what we have usually when we have a screening, okay, usually we have the program, it's come together with the screening. We need to know the status of the child as well. But some of the community program or intervention study, they just give an intervention without further assessment. All right. If let's say they have further assessment, usually we need to we need to distinguish between screening and assessment. Yeah. Screening, usually we focus on those who are at risk, right? So usually certain food program, they may screen the child first, the children first, screening, and they categorize the child based on the screening, right? So screening is just those who actually at risk, yeah. But if we talk about assessment, it's more detailed, it's more focused. For example, just now I mentioned about the diabetes, about the fasting blood glucose, for example. We not provide to all the child, to all children, because it's very expensive, right? So if let's say based on the screening, we can see that, oh, this child is very stunted, but somehow the history is very stunting, but somehow the weight is increased immediately, for example, or those who obese, for example, then we go for the assessment, all right? Assessment. So assessment may be conducted at the health clinic, for example, yeah. In Malaysia, let's say we recognize at school program, let's say we recognize them actually obese, for example, we will bring a refrigerator, we give a refrigerator to this child, to the parents, and they have to go to the health clinics, yeah, for further investigation. Right. So it's based on the level. It's not just for everyone, but based on different screening assessment, then we go for diagnosis. Once it's diagnosed with diabetes, and of course, usually the management is more on the hospital. In Malaysia, we go for the hospital or tertiary hospital. Yeah, I believe Indonesia also may have this kind of situation because more of other countries usually we need to screen because we have big population, right? We have many children, so it should be stages for the screening, assessment, and diagnosis. And of course, intervention also depends on this depends on the level. If it's the screening, then we see this how many children actually stunted. Then we provide the intervention, for example, food basket or anything to this child, this group of children. And we have another assessment, and also we diagnose if let's say they have the disease. Is it answer the question? I hope
Yes.
you get the
Thank you
idea.
so much.
Yeah.
Okay, as we have limited time for the Q&A, I would like to apologize to those of you who didn't get a chance to ask. Alright, question and answer session is finally finished. Thank you so much for amazing answer and explanation, Mrs. Noor. All of the questions has been answered. Dear all participants, I hope you're not easily satisfied with the explanation above and try to find out more about the explanation given. Okay, before we end this session, allow me to read the conclusion about our discussion today. The conclusion is stunting is not merely a problem of impaired physical growth, but an early life marker of metabolic vulnerability that increases the risk of insulin resistance and type 2 diabetes mellitus in later life. This condition reflects chronic undernutrition during the critical first 1,000 days period, which cause permanent changes in pancreatic development, beta cell function, and body composition, particularly a reduction in skeletal muscle mass, which is crucial for glucose metabolism. This risk is further exacerbated by unbalanced catch-up growth, where excessive accumulation replaces lean muscle mass, terribly triggering further metabolic dysfunction. Therefore, a comprehensive approach that includes early growth monitoring, metabolic risk detection, and balanced nutritional intervention is essential to prevent stunting and reduce the global burden of early onset diabetes. Finally, now we have reached the end of this session. I would like to say thank you to Mrs. Noor as our speaker for the great webinar, and also to the audience for the active participation. Okay, before we end this session, we have a certificate of appreciation for you as a speaker, Mrs. Noor. To IT, could you help me for screen certificate, please? Okay, Mrs., this is a certificate from us. Hopefully this is useful. And maybe we can take picture together, Mrs.? Okay, everyone, open your camera and give your better smile. To IT team, could you help me for screenshot the picture, please? Okay, we can screenshot this slide. 1, 2, 3. Okay, that's really good. Okay, we have done take some pictures together, and I will say something to you, Mrs. Noor. You did great today, and it's such a great time for us to have a discussion with you. Thank you so much, Mrs. Hope you always healthy and happy every day.
Thank you. Thank you so much.
Okay, everyone. Last but not least, I would like to extend my appreciation for all of us for learning together in this session. Please give applause. Ladies and gentlemen, before we proceed to the next session, we would like to take this opportunity to acknowledge and thank to our fellow sponsor, Bank BCA, Sarirati, and Koperasi for their generous support in making this event possible. Thank you for your trust and support. I'm Devi Rahmawati Iksan as the third moderator as per leave. I'm hand over it to the next moderator, Lazila Berliani Hidayah. The stage is yours. Thank you. Wassalamualaikum warahmatullahi wabarakatuh. Assalamualaikum warahmatullahi wabarakatuh. Good morning to our distinguished speakers, honorable guests, respected lecturers, and their participants. Welcome to this Zoom meeting of International Webinar of Midwifery Student Association 2026. Tasikmalaya Health Polytechnic of the Ministry of Health. Presented by team Golden Indonesia Giving Smart Parenting, Managing Stunting in Children to Prevent Double Office Diabetes Mellitus, in realizing a healthy and intelligent generation. Thank you to the third moderator for allowing me to host this webinar session. I am Azila Hidayah, and it is my honor to have an opportunity to be a moderator for this webinar session. First of all, let us say thanks and pray to Allah Subhanahu wa Ta'ala for giving us blessings until we can gather in this place. Alright, everyone, I will introduce the first speaker. She is Mrs. Wiwin Tarsih Purnamasari, Bachelor of Applied Science in Midwifery, Master of Health. And before we start discussing, let me read the CV of our fourth speaker. To the IT team, could you help me for share screen the CV? Mrs. Wiwin Tarsih Purnamasari, Bachelor of Applied Science in Midwifery, Master of Health. She graduated with a diploma in Midwifery in Bandung, followed by a bachelor's degree in Midwifery Education from Gajah Mada University. She then obtained her Master of Public Health from the University in 2007. And recently completed her professional midwifery education program in 2023. Mrs. Wiwin had a profound career in healthcare and academia. She began her journey on the ground as a village midwife in Garut Regency, where she was recognized as an expert village midwife in 1969. Since 2002, she has dedicated her expertise to raising the next generation in healthcare professional as a lecturer at Poltekkes Kemenkes Tasikmalaya. On top of that, she is actively involved in professional organization, notably serving as the secretary for the Indonesian Midwifery Association (IBI) for the Tasikmalaya City branch from 2015 to 2023, and worked as an item developer and require for Aiken. As an expert speaker, she is a certified facilitator for normal neonatal and delivery care or ATN, a trainer for clinical preceptor, and has been invited to speak at various forums, including international seminars on midwifery roles in post-disaster care and international webinars on diabetes mellitus. And I think Mrs. Wiwin has already joined us right now. Excuse me, Mrs. Are you there?
Yes, of course I'm joining just.
Alright. How are you, Mrs.?
I'm okay today, and are you?
Glad to hear you. That's really good, and thank you for joining us today. But before we start discussing, let me tell the audiences how this presentation will go. For the first, Mrs. Wiwin will present the material for 30 minutes, and after that, there will be a 10-minute for the question and answer session. Okay, Mrs., may I ask whether the presentation slide will be shared by our commute, or will you be sharing your screen yourself?
Okay, maybe it's possibly by myself.
Okay. Alright, Mrs., have you ready for sharing your experience and knowledge to us?
Okay, I'm trying to sharing about some knowledge, but
Okay, now
let me.
that's right.
Yeah, okay. Let me to share screen our the material. Is they can you can hearing my voice with it exactly?
Yes, I can.
Yes. Okay. Okay, good morning everyone, and healthy greeting to all international webinar participants, and thank you for joining me today. Yeah, my name is Wiwin. I'm from Poltekkes Kemenkes Tasikmalaya. It's very honored to be able to share knowledge and experience regarding the strategic role of midwife. Yeah. I will be presenting on a highly critical topic as a bridging science and lifestyle, even empowering midwives in modern diabetes prevention. Throughout this presentation, our primary focus will be on the vital importance of evidence-based prevention and specifically how this proactive care must be begins right from the preconception stage. Okay, before I continue with explaining this slide, I have a question for you all as an international webinar participant. Why must we start curing diabetes mellitus before pregnancy? Why? Maybe someone has an answer? We can make an interactive process. What should we start from the preconception care? Why must we start before pregnancy? Anyone know? Okay, let me going to the next slide. This is a global public health emergency in diabetes mellitus. Let's begin by looking at the scale of the issues, which has truly become a global public health emergency. Currently, the world is facing a very significantly increase in cases of diabetes mellitus, right? Including in women of reproductive age. 1 in 7 pregnancies worldwide is affected by gestational diabetes or hypoglycemia, and dooming in the country, in our country, that's mean in Indonesia, the situation is critically. We currently have a 10.8% prevalency of type 2 diabetes, placing us in the global top 10. Yeah, it's amazing. Top 10 in the world. Diabetes is no longer a purely individual health problem, but has evolved into a global public health challenge that impact women's quality of life, pregnancy, neonatal health, and even the health of future generation. What is the driving all this? At the below, we can see the modern driver rapid lifestyle shift toward ultra-processed foods, high sugar diets, and decreasing physical activity among young population. We call it Indonesia mager. Yeah, where many teenager is only just mager. Yeah, let us to the next slide. What is the danger of the reactive approach? This slide illustrates the dangers of the traditional reactive approach. We know that waiting until a problem arises during pregnancy to address it. As you can see, hyperglycemia triggers a dangerous domino effect. You know, domino effect. For the mother, maybe we can following the top the part maternal impact. It increased the risk of preeclampsia, gestational hypertension, cesarean delivery, and postpartum type 2 diabetes. And ultimately, maybe for the baby, fetal neonatal impact, maybe it's leading to macrosomia, neonatal hypoglycemia, respiratory distress, and childhood obesity. So it's can we see at the bottom at the part, the impacts are equally diverse. The key takeaway at this slide is here is writing at the bottom, intrauterine hyperglycemia fundamental alters vital metabolic programming, demanding that we intervene before conception. That's why with the question before, Why preconception? Why must we start before pregnancy? Because the principle is simple. Healthy women before healthy pregnancy. That means preconception is critical window because organogenesis begin is the first semester. Okay, in this slide, I would like to explain about what is DOHAD. This is a paradigm with diabetes mellitus. So the danger is the reactive approach. We can see the vicious cycle. We can see the vicious cycle, understanding the development of origin of health and disease. DOHAD. Development, origins of health and disease, the intergenerational cycle of disease. Maybe the DOHAD reveals an intergenerational cycle of disease, maybe start from maternal gestational diabetes leads to altered fetal metabolic programming. This predispose the child to obesity and insulin resistance, which eventually develop into adult type 2 diabetes. And the vicious cycle continues into the next generation. However, right in the middle is where midwife intervention act as the skisser. Maybe midwife intervention can be cutting to cut this cycle. As the quote on the right remind us, mother metabolic health is the biological investment in the next generation. We must ensure women is healthy before she enters a healthy pregnancy. In this slide, the midwifery paradigm shift, we make an illustration. To achieve this, we need a paradigm shift in midwifery. We must move away from the traditional model on the left at the gray color toward the evidence-based modern approach on the right. The maybe is the what is color blue or green green colors, yeah, green colors. The first is traditionally our primary focus with entires, yeah. I focus with strictly on intrapartum care and delivery. Now it must expand to preconception. Maybe at traditional midwifery we know intrapartum delivery the first, but now with evidence based how to prevent diabetes mellitus in pregnancy still start from the preconception and life cycle. Our clinical mindset as much a shift from merely acting to complication through proactively screening for risk and preventing them. And furthermore, we must transition the patient role from a passive recipient of care into an empowered decision maker. And as ultimately our scope of influence is expanding how to from managing individual pregnancy to improving intergenerational community health. Maybe this is a key message that's how to managing diabetes mellitus pregnancy start from the preconception. This is an ecosystem of continuous care. This shift requires to view women's health an ecosystem, how to continuous care prevent diabetes mellitus in gestational or pregnancy. It starts early in adolescence with the nutrition education and obesity prevention. Why should make a nutrition education to obesity prevention? Maybe in this midwife are uniquely positioned at the first line of defense. Unlike other health professionals, we provided continuity of care from adolescent and preconception, to pregnancy and the postpartum period. This proximity allows us to build therapeutic relationship and act as health behavior change agent for women and their family. That's mean how to midwife make education nutrition with wisely by to prevent obesity at pregnancy. So moving into the preconception, we focus on risk identification and BMI optimization, yeah, body mass index, right? Yeah. During the antenatal, early detection of gestational diabetes mellitus is crucial. This is followed by self-delivery management, and finally, postpartum the bottom. Yeah, postpartum is carry focusing on exclusive breastfeeding and sustain lifestyle coaching. As highlight at the bottom, midwife have the longest windows, most consistent of opportunity to prevent disease before it progresses to serve severe complication or gonna be going to the hospital. Yeah. This graph reflects the illustration why we cannot wait until pregnancy to intervene. The critical window is closest early in the pregnancy. The red curve shows organogenesis. Is organogenesis during in the first trimester in pregnancy. This is illustrated from start from the first week, second week, and till the 8th week. Fetal organ development. Notice that it peaks very early, but between weeks 3 till 6 weeks. Yeah. Early hyperglycemia increases risk to congenital anomalies, miscarriage, and stillbirth before standard prenatal care even begin. That means this is the critical period in the pregnancy to be prevent diabetes mellitus and skip to congenital anomalies. However, this typical discovery of pregnancy and the first antenatal visit usually don't happen until around week 8. As shown by the magnifying glass, typical discovery of pregnancy of first antenatal visit is very important. But this time, early hyperglycemia may have already increased the risk of congenital anomalies or miscarriage before standard prenatal even begins. As the evidence called out from a nature meta-analysis, this number just show as a proof that significantly reduce the risk of gestational diabetes. Yeah, maybe many research by meta-analysis show a number of pregnancies proves that pregnancy lifestyle intervention will significantly reduce gestational diabetes mellitus risk. The next slide, I would like to explain about the evidence-based prevention toolkit. So, what practical tools do midwives have for pre-conception care? This is our evidence-based prevention toolkit. The first, weight optimization. The goal is creating a healthy metabolic environment before conception, not just reaching an ideal weight. The second, physical activity. We must prescribe at least 150 minutes of moderate aerobic activity each week to improve glucose metabolism. So at the third, nutritional counseling is more important to promoting low glycemic index, high fiber diets, and eliminating ultra processed food using practical, culturally sensitive advice. And the fourth, early risk screening, proactively identify family history of diabetes like polycystic ovary syndrome, obesity, and age-related risk. As evidence-based lifestyle education, our primary tools for prevention is education. We promote we know in Indonesia, you know about isi piringku. Yeah, isi piringku is the balance plate, yeah, limiting sugar, salt, fats, and achieving at least 150 minutes of moderate physical activity per week, as recommended by the WHO. This educational, be particular, cultural, sensitive, and easy to implement in daily life. Yeah. So just remember, isi piringku in Indonesia we call is should be to skip seblak or another food, yeah, junk food was like that. Okay, I would like to going to the next slide. At the postpartum, preventing the transition to type 2 diabetes mellitus. We must recognize that our care extend far beyond delivery for women who experience gestational diabetes. The postpartum period is ultimate critical window to prevent the transitional to full type 2 diabetes. Our post-delivery strategy focuses on four key areas: promoting exclusive breastfeeding, to reset of metabolic, so which act as a powerful metabolic reset, sustain a health BMI. That's mean how to we depend balancing healthy body mass index and physical activity with at least 150 minutes each week to make an activity. So, and the second one is ensuring schedule blood glucose rescreening and providing strategic family planning counseling. As the bottom part, as the message at the bottom clearly states, women with a history of gestational diabetes are at extreme risk for developing type 2 diabetes within a few years. Care cannot stop at birth, but prevent better than curing. Moving to the next slide, the 10th slide illustrates the art of behavioral change. Having clinical knowledge as our toolkit is only the first pillars on the left. Maybe the left side is this slide. The ultimate goals is the pillar on the right, sustainable lifestyle change or self-efficacy, to bridge the gap between knowing how to do and actually doing it. Midwives must utilize motivational interviewing, cultural sensitivity, and emotional support. How to this what is called? This is the essence of women care center care. The midwife shift from simply dictating health orders to helping women set realistic targets, build internal motivation, and take control of their own metabolic health. That means we do face some challenges, such as lifestyle, how to the digital misinformation today, and limited access of healthcare in rural areas. However, this bridge is challenges our opportunities for midwives to innovate using some information for literacy at the gestational diabetes mellitus. In the next slide is overcoming modern barriers. Midwife as a midwife. Implementing this change is without challenges. That means how we can make something positive without challenges. On this slide, we address how to overcome three major modern barriers. The first is the urban lifestyle. The second is digital misinformation. And the third is health inequity. We can move at the first. We can combat this by leveraging community classes, peer support group, and posyandu remaja. You know posyandu remaja because the posyandu remaja will be make something with how to interaction peer is the same of the teenage. Yeah. So at digital misinformation, we are digital promoters, utilizing health application, wearable technology, and telehealth to expand our care reach. We act as behavioral counselor. Maybe we following the development of technology right now. We can act as behavioral counselor, fostering self-efficacy and guiding in incremental lifestyle change. And importantly, we are interprofessional collaboration teaming with dietitian, doctors, and community public health community leaders to provide comprehensive care. How to interprofessional collaboration localized public health partnership? Maybe it's starting from the educational program. It's like in the Poltekkes Kemenkes Tasikmalaya, even in jurusan kebidanan, we have some information about interprofessional collaboration we did in the class. Yeah, the next slide. This is how to expand mandate of the modern midwife. Maybe the midwife will be acts as a health educator, digital promoter, behavioral counselor, and interprofessional collaborator. This is relate with a slide before. Because of these evolving challenges, this slide defines the expand mandate. We wear many hats today. We are health educators, delivering cultures, contextual and participatory nutrition education. We are digital promoters, utilizing health application like Satu Sehat or learning management system e-health. Yeah. So wearable tech and telehealth to expand our carriage. We act as behavioral counselor, fostering self-efficacy and guiding incremental life change. Yeah. How to make a community leaders positive to provide comprehensive care by exactly. In this slide is an imperative for practice. To summarize our clinical approach, this slide lays out 3 core imperatives for practice. Number 1 is start before pregnancy. We must active how to integrate diabetes screening in lifestyle coaching into the routine pre-marriage and preconception care. That means it is start from the teenage. Teenage is a part of the preconception. And the second one is anchor in evidence. All of our nutritional and physical interventional must be based on validate clinical data, not outdated tradition. You know the traditional the traditional cultures. And the number 3, how to empower the community. We must recognize that when a woman understands her metabolic health, she dictates the nutritional and behavioral standard for her entire family in the next. We move in the next because the woman will be going to the family planning and building a family code. So in this slide, empower midwives create empowered women. This is a jargon. And how to empower women? Because the empower women create healthy generation. That means the healthier generation start from now when women getting teenage. Preventing diabetes is not just about controlling blood sugars. It is about securing the metabolic future of the world, starting before conclusion, before conception. Sorry. The preventing of diabetes is not merely about the blood sugar. It's about creating a healthy future to health women before healthy pregnancy approach. Midwife serve the vanguard in this effort, transitioning the healthcare paradigm from curative to promotive and preventive. As the guiding principle states, empowered disease midwife create empowered women, and empowered women create healthy generation. Thank you. Let the paradigm shift in the preconception care. Thank you. This is last slide from me.
Right. Wow,
The
such an
time
insightful
how
material,
disseminated
right?
data.
Right, now we will move to the question and answer.
Hello? Are you there, Aja?
Sorry. Wow, such an insightful material, right? Alright, now we will move to the another session. This is question and answer session. If you want to ask, you can write it down in our chat room, or you can click the raise button hand, the hand button. Then
Hello, the community. I can hear something sound from there.
sorry, there is sorry, there is a little trouble. So, wow, such an insightful material, right? In our chat room, or you can click the raise hand button. Then tell your name shortly and then tell your question. Excuse me, miss. Will the question answered immediately or will they be collected first?
Hello? I can hear your voice right now. I can hear your voice. Maybe the device just insufficient.
Sorry, miss. Am I audible? Am I audible, miss?
Your audio is just small.
there is a little trouble. Am I audible?
Yes, of course, it's sound good.
Alright. Wow, such an insightful material, right? Now we will move to the question and answer session. If you want to ask, you can write it down in our chat room, or you can click the raise hand button and then tell your name absolutely. So tell your question. Excuse me, miss. Will the question will answered immediately, or will they be collected first?
Maybe if the question will be answered the first.
Alright. Okay.
Okay, here's I have a question from Ita. Ita, the question from Ita is do you think maybe I will do the last of the question. Do you think current educational approaches are sufficient or should they be redesigned? Okay. Yeah.
Alright, miss.
Thank you for the question. Hello? Can you hear me? Can you my voice?
Yes.
Yeah. Okay. Are we starting with the question from Ita? Ita, maybe honestly, I don't have personal clinical experience about this, yeah. But I can provide you a comprehensive evidence-based analysis, but how to significant in modern midwife and prenatal care by the sufficient by educational? Yeah, maybe exactly. There is need redesigning antenatal education because the approach sufficient but not with a model, but maybe it's insufficient with women was like by the culture in the rural, like current approach often fail because they are reactive and late. Educational usually start in the first second trimester, by which point fetal metabolic programming has already begun by organogenesis since the first trimester. Maybe early placental hormones are already driving insulin resistance. Yeah. So what should we do with the situation? Maybe evidence just management the patient make immediately multidiscipline care. Maybe at the before slide I was explaining education would be start from the early pregnancy is not the second trimester or the third trimester, because if we have educational program to the women is getting late. Yeah, and the second one is medical intervention is necessary. Maybe we have to make a collaboration with the doctors or another profession like a dietitian. Should be make diet how to approach when we give a educational program to the women. Maybe right there for it. Did you satisfaction with my answer?
Thank you to
Hello,
Mrs.
Ita.
Wiwin.
Okay, my pleasure, Ita. Thank you for your question.
Yes. Right, miss. There is a questionnaire from Akila Nayara. So to Akila, please welcome to tell your question.
Okay, thank you, moderator, for allowing me to speak. Let me introduce myself. My name is Akila Nayara, and I'm a midwifery student. I'd also thank you for Mrs. Wiwin for insightful and inspiring presentation. And I would like to ask, many women seek healthcare only after they become pregnant. In your opinion, how can midwives effectively promote preconception care among women of reproductive age who are not yet planning a pregnancy? I think that's my question. Thank you.
Okay. Okay, thank you. We directly to answer. The moderator, can I directly to answer the question from Akila?
Yes. Yes, miss.
Yeah. Okay, thank you. Akila, this excellent questions. Yeah, I know what you feel. How to make a promote to the how to make a educational promoting to the women pregnancy, but you have experience about the pregnancy. But you as a midwife student have some information by college by what is called the MORS is mata kuliah asuhan kebidanan, ya. Maybe the antenatal care, how to the pathophysiology at the pregnancy. Yeah, is don't worry. If you have a family experience, that's mean have not yet married, but it's you have to more information from your lectures when you have learning at the class by book by manuscript or another information, because this is a technology development is so high, and in the worldwide you can browsing searching in many resources information. But don't worry, as a midwife a student, you can have a competency as a educator in midwifery. Okay. Yeah, don't worry. Don't worry. You can have some information or experience it when you practice in the public health service or the hospital or the community. You can get some more experience by discussion with a woman, discussion with a teenage, still start from the conception. How to the rise your competence as a candidate of midwives. Maybe like that. My answer for you. Do you get it?
Okay. Thank you, Mrs. Wiwin, for your answer.
My pleasure.
Alright, thank you, Mrs. Alright, there is a question from our chat room. This is from Mrs. Lesti. The question is, I would like to ask question, ma'am. What strategies can be used to engage partners and family members in supporting lifestyle change so that the responsibility doesn't fall solely on women?
Okay, thank you for the question, Lesti. Yeah, I'll try the answer with evidence-based perspective that shifting the burden of health from the individual women to the entire family, right? Yeah. Okay. When the responsibility of the preventing gestational or type 2 diabetes falls entirely on the mothers, it creates immense psychological stress and increases how to the risk of the behavioral relapse. As highlighted in the presentation framework, before before I done with my presentation, when a woman understands her metabolic health, she dictates the nutritional and behavioral standard for entire family. How to make a supporting lifestyle change each for engage partner and family members. Maybe we can start from the maybe was like is the clinical. If you recommendation you make a recommendation, sorry, make a recommendation if the woman coming to make antenatal care, maybe you can ask to the women combining with her partners. So midwife can give educational each others from the spouse, from the partners, maybe women and the spouse and the partners and her partners, and uh, give to the something what is called the some information about the what is the gestational diabetes mellitus will be prevented by family members supporting, so the women will be healthy in the in the next time, and a newborn have healthier in the next generation. Yeah, you can maybe you can open some resources as a midwife responsibility. Yeah, because there are several effective strategies to active engage partner and extend family members to make a family with a healthy in for the next time or the next generation. Maybe like that to Lesti. I hope you are satisfied with my answers. If you have no satisfied, you can search much more, buy more resources, because this is a whole in the worldwide by technology. Okay, thank you.
Right. Thank you, Mrs. So, is there any question? Alright. The question and answer session is finished. Thank you for your amazing explanation, Mrs. Vivian. All of the
My pleasure.
question has been answered. Okay, everyone, before we end this session, allow me to read the conclusion about our discussion today. True material care doesn't begin when a pregnancy is confirmed. It starts when we empower a woman long before she even conceives. By stepping up as modern midwives, we have the unique opportunity to break the silent, intergenerational cycle of diabetes, shifting our focus from merely managing complications to proactively cultivating lifelong metabolic health. When we support women through compassionate, evidence-based guided, and empathic coaching, we are not just protecting one pregnancy, we are actively rewriting the health story of generations to come. Finally, now we have reached the end of our session, and I'd like to say to Mrs. Vivian as our fourth speaker to the great webinar, and also to the audiences for to the active participation. We got a lot of knowledge from here. Mrs. Vivian, we have certificate for you of appreciation as a speaker. To the IT team, could you help me for searching the certificate? Alright, Mrs. Here's the certificate of appreciation from us. May it serve as a meaningful recognition for your contribution. Okay.
Thank you for the chance. Thank you the certificate. It's more maybe it's so important for me as a document. So before I leave in this session, I would like to say thank you for all the committee, all the participants in the international webinar today. Have a success for the next time. Thank you.
You're welcome, Mrs. Okay, before we end this session, maybe could we take some pictures together, Mrs.?
With my pleasure.
Okay, everyone, open your camera and give your best smile, please. To the IT team, could you help me for screenshot this picture? Okay, we can screenshot in 1, 2, 3. Oh, that's really good. Alright, we have done take some pictures together. And I would like to once again express our deepest gratitude to Mrs. Vivian. It has truly been a wonderful opportunity for us to have discussion with you. Thank you, Mrs. And we hope you always stay healthy and happy.
Thank you, thank you.
Last but not least, I would like to extend my appreciation to all of us for learning together in this occasion. May you always happy even after joining this webinar. Finally, I am Lazila Berliani Nur Hidayah as the fourth moderator as for leave. Now we will move to another session with the next moderator, Nabila Putri Nur Armianti. The time is yours.
Thanks to Lazila Berliani Nur Hidayah for letting me to lead this session. Assalamualaikum warahmatullahi wabarakatuh. Good morning to our distinguished speakers, honorable guests, respected lecturers, and dear participants. Welcome to the Zoom meeting of International Webinar on Midwifery Student Association 2026, Tasikmalaya Health Polytechnic of the Ministry of Health. Present by TIP, Golden Indonesia begins with smart parenting, managing stunting in children to prevent double the risks of diabetes mellitus, and releasing a healthy and intelligent generation. I'm Nabila Putri Armianti. It is my honor to have the opportunity to be a moderator for this webinar. First of all, let us say thanks and pray to Allah Subhanahu wa Ta'ala for giving us the grace and of health and safety so that we can gather in this webinar happily. Okay everyone, I will introduce our last speaker for today. She is a lecturer at the Midwifery Study Program of Cirebon, Tasikmalaya Health Polytechnic of the Ministry of Health. Mrs. Pepi Hapitria, Bachelor of Applied Science in Midwifery, Master of Public Health. Before we start discussing, let me tell read the CV of our speaker. To the IT team, could you help me for share screen the CV, please? Okay, it is my pleasure to introduce our last speaker, Mrs. Pepi Hapitria, Bachelor of Applied Science in Midwifery, Master of Public Health. Mrs. Pepi Hapitria was born in Sumedang on October 4, 1979 and currently resides at Puri Sartika Residen, Tohit District, number 2B, Tukmudal Village, Sumber District, Cirebon Regency, West Java, Indonesia. She is a lecturer in the Midwifery Study Program at Cirebon Campus, Tasikmalaya Health Polytechnic of the Ministry of Health, and also serves as a certified breastfeeding counselor. She completed her education at the Cirebon Academy of Midwifery 2001 and her Bachelor of Applied Science in Midwifery Education from Pajajaran University 2004, obtained her Master of Public Health in Maternal and Childhood Reproductive Health from Gajah Mada University 2011 and completed her Midwifery Professional Education at Tasikmalaya Health Polytechnic of the Ministry of Health 2022. Before becoming a lecturer, she worked as a midwife at Dharma Raja Community Health Center, Sumedang Regency from 2001 to 2002 and has been serving as a lecturer since 2003. Okay. In addition to her academic responsibilities, Mrs. Pepe is actively involved in various professional organizations and has participated in numerous national training programs, particularly in breastfeeding counseling and maternal and childhood. She has also been actively involved in various research activities and professional achievements, as listed in her CV. Okay, I've done to read the CV of Mrs. Pepe, and I think Mrs. Pepe is already joined with us right now. Excuse me, Miss, are you already with us?
Yes, I'm here, Nabila.
Okay, how are you today, Miss?
I feel great.
Oh, that's very good to hear that. And thank you so much for joining with us right now. Before we start discussing, let me tell the audiences how the presentation will go. For the first, Mrs. Pepe will presentation the material for 30 minutes, and after that there will be a question and answer session for 10 minutes, and followed by a conclusion. Okay, Mrs., may I ask whether the presentation slides will be shared by our committee or will you sharing your screen yourself?
Okay, allow me to share my screen, right?
Okay.
Can you see my screen?
Yes. Okay, Miss, have you ready to deliver today's material?
Yes, okay.
Okay, now let's right away listen to the material that will be presented by Mrs. Pepe about metabolic programming, how childhood stunting paves the way for future diabetes. Alright then, Mrs. Pepe, I welcome you to present the material now.
Okay, thank you, Nabila. Good morning, everyone. Good morning, Nabila. Welcome to International webinar, yeah, International webinar, and I'm Pepe Hapitria. I can to explain about metabolic programming, how childhood stunting paved the way for future diabetes mellitus. And I'm glad to be honored at international webinar, and so would also like to thank before for Director of the Tasikmalaya Health Polytechnic, Mrs. Dini Mariani, for giving me the opportunity to speak here today. All right, the slide. Yes, we have six. Yeah. Okay. All right. We have six topics. We will cover six interconnection topic. We begin to introduction about metabolic programming. This is the fundamental concept of metabolic change from the earliest stage of life. And then we can discuss about the first 1,000 days of life, the critical window for pregnancy until 2 years of age. And we can discuss about stunting, definition and cause. Of course, we find three causes about stunting: nutritional, infection, and environmental contributing factor. Yeah, another topic is long-term consequence of stunting. This disrupts growth and metabolic dysfunction. And the five is mechanism of metabolic programming. Why the body adaptation to early life malnutrition. And the last, we can to connect the stunting and insulin resistance, the pathway to diabetes mellitus. Okay, before we give the fact and the numbers of the stunting. Okay. We can explain about illustration. That's the child who have born from the mother give deficiency nutrition. He had to height significantly below the growth standard. What is the connection between stunting as 2 and diabetes at the 22 years? The answer is lies in metabolic programming. Okay. When the child is 2 years old, he is much shorter than other children of the same age, and we call this is stunting. Now, let we jumps ahead to 20 years. The child is now a young adult. He lives a city and often eat fast food like instant noodle and drink sugary drink. He doesn't not look overweight. Also, everyone thinks he is a hot. But one day, maybe the doctor diagnosis that have diabetes type 2. Everyone feels sad. How can this happen? Is this even overweight? The answer is metabolic programming. Because he did not have enough nutrition when he was very young, his body learns to work in a different way. There's hidden change stays with him for many years. Slowly, they increase his chance of getting diabetes as adults. Today, we will can to know how stunting is early life can impact her hurts many years later, and why good nutrition is the first years of life is so important. Okay, we can see this slide. We have the analog about system that the infant's body function is like building house. When we build the house, maybe we have a strong foundation. So nutrition condition in the womb represent the building process. The outcome of the determine how the body function throughout life. Of course, in this slide, we can see our body is same like the foundation of the house, and our body is born during pregnancy and the first 2 years of life. If a baby does not get good nutrition during this time, their organ like pancreas and then liver may not develop properly. This can cause health problem later like diabetes. It is very important concept in global health research. So what happened early in the life really matter is program the body for the future. Let's we talk about first 1000 day of life. In Indonesia, kita mengenal adanya 1000 hari pertama kehidupan atau 1000 hari HPK, ya 1000 HPK. There is 1000 days start from the beginning pregnancy until a child is 2 years old. The stage 1, trimester 3, 0 until 3 months. This is a formation of vital organ. This is the most important time for a child to grow, and during this time, of course, good food and then love, care, and learning helps the body and brain grow strong. What happens during the 1000 day can affect health for the rest of life. Right. And stage 2, this is from 3 until 9 months. This is trimester 2 and 3. The condition, this is when the baby body begin to form. The brain, heart, and the other organ start to grow. The mothers need healthy food and nutrition, of course, like folic acid, like iron or iodine, to help the baby grow very well. And the next stage, this is the later pregnancy. 3 until 6 months. During this time, the baby grow very quickly. The brain and body become bigger and stronger, of course, and the baby needs enough protein. DHA, calcium, and zinc. If the baby does not get enough nutrition, the body may not develop in the best way. Then stage 3, from birth until 6 months. This is an important condition because the baby start to get exclusive breastfeeding. And then he have got microbial development and tentunya adanya imunitas, immune maturation. And 6 months until 24 months, this is a toddler or baduta. The baby can to have the complementary feeding, of course with breastfeeding. This is a critical phase for linear growth. The case of nutrition deficient during this period are permanent. They cannot be fully resolved once the critical window has closed. Okay, the topic is stunting. This is we can to explain about definition and cause. 3 main cause of stunting. We have the first is nutrition factor, and then infection factor, and the last factor is environmental factor. For the first factor is nutrition. Stunting's mean is to just not too short for their age, especially their height is more than 2 standard deviation below from WHO growth standard. But this is the nutrition factor, lacks of K nutrition. The baby needs protein, zinc, iron, and vitamin, especially during pregnancy and early childhood. And if they have a poor breastfeeding practice and low quality, can make the baby to be a stunting. And infection factor, repeat infection like direct and respiratory illness, and parasite reduce nutrient absorption, make the children who are often sick cannot use food properly for grounds. And the last factor is environmental factor. The family have poor sanitation and use unsafe drinking water and limited access to health care. There create a cycle of infection and malnutrition that is hard to break. This is a long consequence have the children stunting. The first is the effect from to cognitive and brain development. The stunting children often have lower IQ. And then for memory and reduced learning ability, the brain need proper nutrition in the first 1,000 days to form billion of connection. One miss, this cannot be full recovery. And then if they do not get it, they may have low IQ. Also, this damage cannot be fully recovery later. And the consequence of stunting, the second is physical growth and development. Not just height, but also bone density, muscle mass, and organ size, of course. The third is the metabolic system change. The body learns to save energy because it's experienced scarcity. This was useful thousands of years ago when food was rare atau kebutuhan makanan langka. But today when food is plentiful, this thrifty body stores too much fat and increase the risk of obesity. Of course, to be a diabetes. And the last consequence is weak immunity system. The immune system become weaker, so stunting childs get sick more often. And when they are sick, they cannot absorb nutrition very well, so it is become a various cycle. Okay. This slide, I think this slide explains clearly from a speaker before. This is about 30 phenotype hypothesis. Baik, dari slide ini tentunya kita bisa memahami bahwa bagaimana malnutrisi pada masa awal kehidupan memprogram tubuh tubuh secara bertahan untuk dia tetap bertahan hidup. Dan ketika seorang bayi dalam kandungan atau anak kecil tidak mendapatkan cukup makanan pada saat usianya, tubuh akan mengalami perubahan yang permanen gitu ya, khususnya kalau berbicara di sini adalah adanya pankreas yang memproduksi lebih sedikit sel untuk menghasilkan insulin. Dan organ hati juga ini menjadi kurang efisien ya dalam memproses gula tentunya, sehingga akan berdampak terhadap otot menjadi kurang sensitif terhadap insulin. Sedangkan otak ini adalah merupakan organ yang memang harus kita prioritaskan gitu ya, sehingga untuk mendapatkan nutrisi terlebih dahulu itu adalah otak. Ya, sementara organ lain itu mendapat lebih sedikit nutrisi gitu ya. Untuk perubahan ini membantu tubuh bertahan pada saat makanan langka untuk diterima gitu ya. Tapi masalahnya ketika anak ini sudah tumbuh dewasa di lingkungan yang banyak makanan gitu ya, tetap saja organnya mengkondisikan diri tetap mendapatkan makanan yang langka seperti saat kecil. Nah, ini yang kita sebut dengan beban ganda nutrisi seperti itu. Itu adalah penjelasan dari slide ini. Next slide. Nah, ini juga sama ya, ini adalah slide sudah tadi dijelaskan juga. Di sini stunting seperti yang telah kita bahas, ini mencerminkan malnutrisi yang kronis ya. Berkurangnya sel-sel beta di pankreas, ya artinya pankreas di sini tidak dapat memproduksi insulin yang cukup. Secara bersamaan, kadang kekurangan gizi yang kronis juga akan meningkatkan kadar kortisol ya di sini dan memicu peradangan sistematik yang rendah sehingga keduanya mengganggu sinyal insulin. Ya, akibatnya di sini sel-sel tubuh berhenti untuk memproses sinyal seperti ini. Ini adalah untuk bagaimana insulin menjadi resisten. Ya, let us look the big picture. This is clinical evidence, stunting and diabetes mellitus risk. Yeah, we know Indonesia face what we call the double burdens of nutrition. One on hand, we have high grades of stunting in children because 2 until 3 increased risk of type 2 diabetes for adults who were stunting as children. Jadi berdampak pada saat kecilnya stunting, dia akan mengalami 2-3 kali kemungkinan mengalami diabetes. The two problems are connected through metabolic programming, and of course 1,049 million children worldwide are stunting. So Indonesia have a national emergency with stunting and a generation with impaired brain development and high disease. This cannot fully contribute to Indonesia children. 60% relative reduction in insulin secretory capacity attributes to suboptimal pancreas development. This is a clinical intervention. How to break the cycle of stunting. We have time for time to be intervention. The first is antenatal. Evidence-based clinical protocol that's gestational diabetes mellitus can to screening with 24 until 20 8 weeks. And then iron folate and calcium supplement have the pregnancy must to have iron folate and calcium supplement. Close monitoring of maternal gestational weekend. Jadi selama kehamilan tentunya ini sudah dilakukan screening dari mulai usia kehamilan 24 sampai 28 minggu. And then postnatal 0 until 6 months. This is we can to promote the support exclusive breastfeeding for the first 6 months. Breast milk provide perfect nutrition and protect against infection that contribute to stunting. And after 6 months, we can to give the baby complementary feeding phase 6 until 24 months. From 6 months, guide parent on introducing nutrient-rich complementary food, include protein, vegetables, and healthy fats and others. Avoid relying only on rice or carbohydrate. And the last, preventive and promotion. It is an important activity that's educate, teach not just mother, but we can to make the father knows or the grandparent. So smart parenting is finally to give the family efforts. Teach about sanitation and clean water, and then the importance of the first 1,000 days. Okay, we have two intervention to can we have to approach nutrition specific and sensitive intervention. This is from nutrition specific. About medical and nutrition focus, of course, the baby or the pregnant have iron, folic acid, calcium, and protein supplements for pregnant woman, and the prevent chronic energy deficient. Jadi ini diprioritaskan untuk ibu hamil yang memang memiliki kekurangan energi kronis. Ini diberikan tablet Fe, kalsium, dan suplemen termasuk protein. And then exclusive breastfeeding. This is a nutritional protection and epigenetic benefit. And animal source protein, rich complementary foods, and micronutrient supplements like zinc and vitamin A. So ready to use therapeutic food for children diagnosis with severe acute malnutrition. And the other intervention is nutrition sensitive intervention. This is about social and environmental focus, of course. How the family get access to safe water, and then sanitation and hygiene, especially wash for hand, preventing malabsorption and infection. And then food security support for vulnerable and low-income household, and nutrition literacy and responsive caregiving empowerment. Then the last, social health protection or access to integrated health posyandu and routine supplement feeding program. Nah, dalam intervensi yang sensitif ini tentunya terkait dengan sosial dan lingkungan, fokus terhadap lingkungan, bagaimana mendapatkan air yang bersih, sanitasi yang bersih, kemudian personal hygiene, ya termasuk juga untuk akses ke pelayanan kesehatan. Ini adalah dua intervensi yang dapat dilakukan sebagai pendekatan untuk pencegahan stunting. Okay, this is the golden generation smart parenting protocol, and we know there's have 6 golden protocol for parenting. The first is animal source protein from early life. The children must get the nutrition like eggs, fish, and lean red meat provide essential amino acid and drive linear growth. And then monthly high nutrition. Jadi anak harus dibawa setiap bulannya untuk mengukur pertumbuhan dan perkembangannya. Do not wait until the child visible affair short. Conduct routine early stunting detection at every health specialty visit. And it is important, zero ultra processed food and add sugar. Sugary drink impose excessive metabolic burden on children whose body are already programmed for energy conservation. And in 6 months of exclusive breastfeeding, this is the best epigenetic protection available, a natural source of antibody, of course, and prebiotic and growth factor. And the 5 is target micronutrient supplement. This is the baby can give providing iron or vitamin D only in accordance with a clinical recommendation and medical screening result. And the last, of course, child have activity, physical activity stimulation, active play and motor stimulate, it is important, are natural trigger for endogenous growth hormones release. Yeah, before I close this presentation, we have a 6 case takeaway. The first is the hidden crisis. Stunting is not merely a problem of short stature. It is a metabolic crisis that permanent reprogram the body biological blueprint. And 2, the golden window. We know the first 1,000 days of life is an irreplaceable critical period. So nutrition damage sustained during the window is permanent. 3 is metabolic programming. This is early nutrition. The prevention trigger epigenetic adaptation that program the body to store fat and conserve energy, increasing metabolic disease risk for life. 4, the demography time bomb. The stunted children exposed to the modern nutrition station. This is ultra processed for environmental. Based 2 until 3 times greater risk of developing type 2 diabetes mellitus. 5, the frontline defender, health professional, of course, hold a decisive role in breaking this chain through rigorous screening and target nutrition education. And the last, this is investment in 2045. Evidence-based intelligent parenting is the only pathway to metabolical healthy golden Indonesia in 2045. Okay, this is PC Indonesia Emas 2045, di mana a child who grow up healthy today is the guardian of the national tomorrow. Breaking the chains of chronic disease begin in the womb, start now and start with us. Yeah, thank you. And I'm ready to present my presentation. And the last, we back to moderator. Thank you.
Wow, the material is so insightful, right? Okay. Now we will move on to question and answer session. If you want to ask, you can raise hand. Yeah. You can raise hand and telling your name with the question. Excuse me, miss. Will the question be answered immediately or they will be collected first?
Please, you can collect question first. I will answer them later.
Okay. So I got the first question. For the first questioner is from Bintang Indah Juliana. For Bintang Indah Juliana, please to tell the question.
Okay, thank you, moderator. Good afternoon, Mrs. Pepi. Thank you for your informative presentation. My name is Bintang Ida Juliana from the Diploma 3 Midwifery program. My question is, if childhood stunting can increase the risk of developing diabetes mellitus later in life, through metabolic programming, nutritional intervention, and healthy lifestyle. Changes during adolescence or early adulthood still reduce death risk. If so, how effective are these interventions? Thank you, Mrs.
Okay, I welcome Mrs. Pepi to answer the questions.
Yeah, thanks Bintang. Good question. Okay, the Bintang. Could you repeat that, Bintang, please? Okay, if childhood stunting can increase the risk of developing diabetes mellitus later and not through metabolic programming, can nutrition intervention and health lifestyle change during adolescence or early adulthood still reduce the risk? If so, how effective are these interventions? All right. And the good news is the stunting does not mean a person will definitely develop diabetes mellitus in the future. Stunting increase the risk, but the risk can still be modified through nutritional intervention, of course, and lifestyle change during adolescence and early adulthood maybe. In epidemiology, this is refers to as risk reduction, not the complete elimination of risk. Why can the risk still be reduced? This is stunting early in life lead to metabolic program. This adaptive change in the metabolic system that occur during a critical period in the 1000 day hours of life. Their change include maybe the decrease is muscle mass and decrease in the number and function of pancreas, and then impairs mitochondria function and tendency to accumulative physical the fat when energy intake. Also, adolescent or young adults with a history of stunting are advised to consume high quality protein, maybe adequate fiber, fruit and vegetables, and limit simple sugar, and reduce ultra processed food. Apa keuntungannya? This is can to improve insulin sensitive, reduce visceral fat, and of course reduce chronic inflammation. Akan efektif ya pada saat yang dilakukan itu adalah memang hal yang akan meningkatkan fungsi daripada pankreas ya beserta dengan livernya. Nah, kemudian selain itu juga untuk efektivitasnya di sini untuk pencegahan diabetes mellitus dapat meningkatkan diabetes mellitus itu atau menurunkan diabetes mellitus sekitar 40-60% ya. Untuk mencegah obesitas yang sudah terjadi ini sangat penting gitu ya. Tentunya harus dengan aktivitas fisik ya dan kita harus tahu bahwa stunting dengan obesitas ini akan meningkatkan resiko daripada diabetes ya. Jadi apa yang harus kita lakukan, stunting tidak bisa diperbaiki ya, hanya tetap kita memperhatikan lifestyle harus tetap sehat. Yang namanya stunting memang tidak bisa diperbaiki, tapi kita bisa meningkatkan kemampuan atau kapasitas daripada tubuh kita, tapi kita tidak bisa memperbaiki stunting. Ya. Mungkin itu untuk jawabannya, Bintang.
Mrs. Thank you for the answer.
Yes, welcome.
Alright, is there any questions? Alright, question and answer session is finally finished. Thank you so much for your amazing answer and explanation, Mrs. Pepi. All of the question has been answered. Okay, before we end the session, allow me for read the conclusion about our discussion today. The conclusion is stunting is more than a growth problem. It is a long-life metabolic condition that increases the risk of diseases such as type 2 diabetes. The first 1,000 days of life are a critical window that cannot be replaced. Therefore, ensuring proper maternal nutrition, exclusive breastfeeding, adequate complementary feeding, and a healthy environment is essential. By investing in early life nutrition today, we can build a healthier generation and break the cycle of chronic disease in the future. Finally, now we have reached the end of this webinar session. I would like to say thank you to Mrs. Pepi Hapitia, Bachelor of Applied Science in Midwifery, Master of Public Health, as our speaker for the great webinar, and also to the audiences for this active participation. We got a lot of great knowledge from here. Okay, Miss. We also have an appreciation certificate for you as a speaker. To the IT team, could you help me for sharing the certificate, please? Okay, Miss, this is the certificate from us. May the certificate is beneficial for you.
Thank you.
Okay, before we end this session, could we take some pictures together, Miss?
Of course.
Okay, everyone, please open your camera and give your pretty smile. To the documentary team, could you help me for screenshot this picture? Okay, we can start screenshot this slide. 1, 2, 3. Perfect. Alright, now we've done take some pictures together. Let me say something to you, Mrs. Pepi. You did very good for today's webinar, and it's such time for us to having insightful discussion with you. Thank you very much, Miss. May you always have healthy and happy every day.
You're welcome. Thank you.
Last but not least, I would like to extend my appreciation to all of us for learning together in this occasion. May you always happy even after joining this webinar. Please give applause. Finally, I'm Nabila Putri Armianti as the last moderator as for leave. Now, I'm handing over again to the Master of Ceremony. The stage is yours.
Thank you to all speakers and moderators for today's material and discussion. This is such an honor and a good opportunity for all of us.
Ladies and gentlemen, before we proceed to the next session, we would like to take this opportunity to acknowledge and thank our valued sponsors, BCA Bank, Sari Roti, and Koperasi, for their generous support in making this event possible. Thank you for your trust and support.
After the webinar has concluded, all participants are kindly requested to complete the post-test through the LMS. The post-test will be available immediately after the event, and we encourage all participants to complete it independently. Please be informed that the deadline for submitting the post-test is 6 p.m. Western Indonesian time today. We kindly ask all participants to complete and submit the post-test before the deadline. Thank you for your cooperation.
Dear participants, this is us again to serve as the Master of Ceremony for the following event. For the next agenda, we will announce the best questioner that will get a door prize from this event.
The first winner is Siti Nurfaizarus with the question. In your presentation, you mentioned several strategies to prevent stunting, including proper nutrition, clean water, hygiene, healthcare access, and early stimulation. If parents are unable to implement all of these at the same time due to limited resources, which intervention should be prioritized first and why?
And the second winner is Ita Nurfitriyasari with the question, although education about gestational diabetes is routinely provided during antenatal care, the incidence of complications remains high. Do you think current educational approaches are sufficient, or should they be redesigned? Which evidence-based educational interventions have shown the greatest impact on maternal behavior?
Wow, these questions from our audience at this event are truly extraordinary. Congratulations to both winners. Each of you will receive a voucher worth 50,000 rupiah. Kindly contact the person in charge list in the event information to claim your prize. For other questioner who haven't received a prize, don't be discouraged because there are still many opportunities to ask questions at another time.
Before we officially conclude today's webinar, let us pray in gratitude for the successful completion of this event. To lead us in prayer, we respectfully invite Raden Sekar Ayulindra. The stage is yours.
Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Hamdan syakirin, hamdan na'imin, hamdan yuafi ni'amahu wa yukafi mazidah. Ya Rabbana lakal hamdu kama yang bagi li jalali wajhika wa azimi sultanik. Allahumma sholli wa sallim ala sayyidina Muhammadin wa ala ali sayyidina Muhammad. Allahumma ij'al jam'ana hadza jam'an marhuma wa tafarruqana min ba'di tafarruqan ma'suma wa la taj'al fina ma la ma'ana sakiyan wa la mahruma. Allahumma anfa'na bima 'allamtana wa 'allimna ma yanfa'una wa zidna ilman walhamdulillahi ala kulli hal. Subhanakallahumma wa bihamdika asyhadu an la ilaha illa anta astaghfiruka wa atubu ilaik. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Walhamdulillahi rabbil alamin. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you to Raden Sekar Ayulindra for leading us in prayer. May today's webinar bring lasting knowledge and inspiration to us all.
Distinguished guests and all participants, the event of the International Seminar Golden Indonesia begins with smart parenting, managing stunting in children to prevent double the risk of diabetes mellitus in realizing a healthy and intelligent generation. 2026 has been finished.
We would like to express our sincere gratitude to all participants for your active participation throughout this event. Our heartfelt appreciation also goes to all of our sponsors and every party who has contributed to the success of the seminar. Your generous support and collaboration have this made event possible.
Let's close this event by saying Hamdalah. Alhamdulillahirabbil alamin. I am Fatia and
I am Teva.
as a master of ceremony as for leave. We apologize for our mistakes and imperfections. Thank you for your attention and cooperation. Wassalamualaikum warahmatullahi wabarakatuh.
Poltekkes Kemenkes Tasikmalaya is not merely an educational institution. It serves as a crucible for shaping the future health professionals who will occupy every sphere, respond to every challenge, and contribute across all dimensions of the healthcare sector. We are a home for aspiring health practitioners who are prepared to meet the demands of a rapidly changing era. Founded with a spirit of service and commitment to health education, we have now advanced further, emerging as a center of innovation, collaboration, and transformation in the field of healthcare. Within an inclusive and dynamic academic environment, Poltekkes Kemenkes Tasikmalaya provides fertile ground where new ideas are cultivated, potential is defined, and the future of Indonesia's healthcare is envisioned. Students arrive from diverse regions, carrying aspiration and burning passion. At Poltekkes Kemenkes Tasikmalaya, those dreams are nurtured, and that passion is directed. Like seeds planted in fertile soil, they grow into individuals who are strong, intelligent, and compassionate. Our students are not only equipped with theoretical knowledge, but also trained to think critically, collaborate across disciplines, and adapt swiftly. They are future health professionals prepared not only to serve their nation, but also to compete on the global stage.
Assalamualaikum warahmatullahi wabarakatuh. Poltekkes Kemenkes Tasikmalaya is committed to producing healthcare professional with noble character, professionalism, and global competitiveness. We continue to develop as a shining center of excellence, rooted in a combination of professional competencies and virtuous characters. This foundation equips our graduates to compete globally and bring positive impact to community worldwide. We have established ourselves as one of Indonesia's leading health education institutions. Our alumni now serve with high dedication, not only across the institute, but also on the international stage. At Poltekkes Kemenkes Tasikmalaya, we do more than educate. We shape the brilliant future of healthcare in Indonesia. Poltekkes Kemenkes Tasikmalaya, shine. Wassalamualaikum warahmatullahi wabarakatuh.
Poltekkes Kemenkes Tasikmalaya has extended its vision beyond national borders, embracing global outlook. We actively build collaborative bridges with leading universities, hospitals, and health organizations around the world. Through student exchanges, joint research programs, and internationally benchmarked curricula, we ensure that our graduates are not only competitive at the national level, but also ready to contribute meaningfully in global healthcare arenas. Our alumni have already established their presence across various countries, where their expertise is highly sought after, evidence that the quality of our education meets international standard. Poltekkes Kemenkes Tasikmalaya proudly prepares its students to embark on a successful career journey with an extensive network of partnerships and a teaching factory system integrated with the global health industry. Our alumni serve as ambassadors of the nation, carrying Indonesia's name with pride. This is where global careers are born, from Tasikmalaya to the world. Poltekkes Kemenkes Tasikmalaya is not merely an educational institution. It serves as a crucible for shaping the future health professionals who will occupy every sphere, respond to every challenge, and contribute across all dimensions of the healthcare sector. We are a home for aspiring health practitioners who are prepared to meet the demands of a rapidly changing era. Founded with a spirit of service and commitment to health education, we have now advanced further, emerging as a center of innovation, collaboration, and transformation in the field of healthcare. Within an inclusive and dynamic academic environment, Poltekkes Kemenkes Tasikmalaya provides fertile ground where new ideas are cultivated, potential is defined, and the future of Indonesia's healthcare is envisioned. Students arrive from diverse regions, carrying aspiration and burning passion. At Poltekkes Kemenkes Tasikmalaya, those dreams are nurtured, and that passion is directed. Like seeds planted in fertile soil, they grow into individuals who are strong, intelligent, and compassionate. Our students are not only equipped with theoretical knowledge, but also trained to think critically, collaborate across disciplines, and adapt swiftly. They are future health professionals prepared not only to serve their nation, but also to compete on the global stage.
Assalamualaikum warahmatullahi wabarakatuh. Poltekkes Kemenkes Tasikmalaya is committed to producing healthcare professional with noble character, professionalism, and global competitiveness. We continue to develop as a shining center of excellence, rooted in a combination of professional competencies and virtuous characters. This foundation equips our graduates to compete globally and bring positive impact to community worldwide. We have established ourselves as one of Indonesia's leading health education institutions. Our alumni now serve with high dedication, not only across the institute, but also on the international stage. At Poltekkes Kemenkes Tasikmalaya, we do more than educate. We shape the brilliant future of healthcare in Indonesia. Poltekkes Kemenkes Tasikmalaya, shine. Wassalamualaikum warahmatullahi wabarakatuh.
Poltekkes Kemenkes Tasikmalaya has extended its vision beyond national borders, embracing global outlook. We actively build collaborative bridges with leading universities, hospitals, and health organizations around the world. Through student exchanges, joint research programs, and internationally benchmarked curricula, we ensure that our graduates are not only competitive at the national level, but also ready to contribute meaningfully in global healthcare arenas. Our alumni have already established their presence across various countries, where their expertise is highly sought after evidence that the quality of our education meets international standard. Poltekkes Kemenkes Tasikmalaya proudly prepares its students to embark on a successful career journey with an extensive network of partnerships and a teaching factory system integrated with the global health industry. Our alumni serve as ambassadors of the nation, carrying Indonesia's name with pride. This is where global careers are born, from Tasikmalaya to the world. Poltekkes Kemenkes Tasikmalaya is not merely an educational institution. It serves as a crucible for shaping the future health professionals who will occupy every sphere, respond to every challenge, and contribute across all dimensions of the healthcare sector. We are a home for aspiring health practitioners who are prepared to meet the demands of a rapidly changing era. Founded with a spirit of service and commitment to health education, we have now advanced further, emerging as a center of innovation, collaboration, and transformation in the field of healthcare. Within an inclusive and dynamic academic environment, Poltekkes Kemenkes Tasikmalaya provides fertile ground where new ideas are cultivated, potential is refined, and the future of Indonesia's healthcare is envisioned. Students arrive from diverse regions, carrying aspiration and burning passion. At Poltekkes Kemenkes Tasikmalaya, those dreams are nurtured, and that passion is directed. Like seeds planted in fertile soil, they grow into individuals who are strong, intelligent, and compassionate. Our students are not only equipped with theoretical knowledge, but also trained to think critically, collaborate across disciplines, and adapt swiftly. They are future health professionals prepared not only to serve their nation, but also to compete on the global stage.
Assalamualaikum warahmatullahi wabarakatuh. Poltekkes Kemenkes Tasikmalaya is committed to producing healthcare professional with noble character, professionalism, and global competitiveness. We continue to develop as a shining center of excellence, rooted in a combination of professional competencies and virtuous characters. This foundation equips our graduates to compete globally and bring positive impact to community worldwide. We have established ourselves as one of Indonesia's leading health education institutions. Our alumni now serve with high dedication, not only across the institute level, but also on the international stage. At Poltekkes Kemenkes Tasikmalaya, we do more than educate. We shape the brilliant future of healthcare in Indonesia. Poltekkes Kemenkes Tasikmalaya, shine. Wassalamualaikum warahmatullahi wabarakatuh.
Poltekkes Kemenkes Tasikmalaya has extended its vision beyond national borders, embracing global outlook. We actively build collaborative bridges with leading universities, hospitals, and health organizations around the world. Through student exchanges, joint research programs, and internationally benchmarked curricula, we ensure that our graduates are not only competitive at the national level, but also ready to contribute meaningfully in global healthcare arenas. Our alumni have already established their presence across various countries, where their expertise is highly sought after evidence that the quality of our education meets international standard. Poltekkes Kemenkes Tasikmalaya proudly prepares its students to embark on a successful career journey with an extensive network of partnerships and a teaching factory system integrated with the global health industry. Our alumni serve as ambassadors of the nation, carrying Indonesia's name with pride. This is where global careers are born, from Tasikmalaya to the world. Poltekkes Kemenkes Tasikmalaya is not merely an educational institution. It serves as a crucible for shaping the future health professionals who will occupy every sphere, respond to every challenge, and contribute across all dimensions of the healthcare sector. We are a home for aspiring health practitioners who are prepared to meet the demands of a rapidly changing era. Founded with a spirit of service and commitment to health education, we have now advanced further, emerging as a center of innovation, collaboration, and transformation in the field of healthcare. Within an inclusive and dynamic academic environment, Poltekkes Kemenkes Tasikmalaya provides fertile ground where new ideas are cultivated, potential is refined, and the future of Indonesia's healthcare is envisioned. Students arrive from diverse regions, carrying aspiration and burning passion. At Poltekkes Kemenkes Tasikmalaya, those dreams are nurtured, and that passion is directed. Like seeds planted in fertile soil, they grow into individuals who are strong, intelligent, and campus. Our students are not only equipped with theoretical knowledge, but also trained to think critically, collaborate across disciplines, and adapt swiftly. They are future health professionals prepared not only to serve their nation, but also to compete on the global stage.
Assalamualaikum warahmatullahi wabarakatuh. Poltekkes Kemenkes Tasikmalaya is committed to producing healthcare professional with noble character, professionalism, and global competitiveness. We continue to develop as a shining center of excellence, rooted in a combination of professional competencies and virtuous characters. This foundation equips our graduates to compete globally and bring positive impact to community worldwide. We have established ourselves as one of Indonesia's leading health education institutions. Our alumni now serve with high dedication, not only across the institute, but also on the international stage. At Poltekkes Kemenkes Tasikmalaya, we do more than educate. We shape the brilliant future of healthcare in Indonesia. Poltekkes Kemenkes Tasikmalaya, shine. Wassalamualaikum warahmatullahi wabarakatuh.
Poltekkes Kemenkes Tasikmalaya has extended its vision beyond national borders, embracing global outlook. We actively build collaborative bridges with leading universities, hospitals, and health organizations around the world. Through student exchanges, joint research programs, and internationally benchmarked curricula, we ensure that our graduates are not only competitive at the national level, but also ready to contribute meaningfully in global healthcare arenas. Our alumni have already established their presence across various countries, where their expertise is highly sought after evidence that the quality of our education meets international standard. Poltekkes Kemenkes Tasikmalaya proudly prepares its students to embark on a successful career journey with an extensive network of partnerships and a teaching factory system integrated with the global health industry. Our alumni serve as ambassadors of the nation, carrying Indonesia's name with pride. This is where global careers are born, from Tasikmalaya to the world.